Welcome everybody to our November Trust Board here at Humber. Hope you are all well, and we'll start proceedings. I have apologies from Stella Jackson. I don't think there are any other apologies. No, okay, we'll go straight in. Declarations of interest. Obviously, if you need to update, please let Laura know. Are there any items on the agenda that pose a conflict for any colleagues that you want to flag now? No? Great. We'll move on then to the minutes of the meeting held on the 25th of September. Are these an accurate record? Any changes necessary? No. Any matters arising from them? No. Okay. And we also have today the annual members meeting, and just to say thanks for everybody's participation in that, from the board to the governors, to all the staff who came along and others who chose to be with us on that day as well. It was very well attended. Attendance was up from last year, and it was a great chance to obviously have the official, if you like, reports that are necessary at that meeting, but also in the marketplace be able to sort of chat with some of our staff and the different services they use. So thank you to everybody for that. So annual members minutes meetings, any comments on those? No. Is the board happy to approve both sets of minutes? Thank you very much. So we'll go to the action log now. And if I could just give a little update on the action log. Firstly, on the minute 114/24 regarding review of the mental health services at Nottinghamshire Healthcare Trust. Remember, we had a bit of a discussion about this previously, and about which subcommittee might look at this, and obviously it's an ongoing piece of work. And as you can see there, the action is that the quality committee maintains oversight beneath the board with other committees where, as this work develops, being requested to undertake specific pieces of work. For example, it might be for Steph chairing the mental health legislation, that something comes up in discussion around that it might be worth your committee looking at. Is the board happy with that proposal as the action log, and then we can close that? Brilliant, thank you so much. And just an update also from Pete, which will get included as an update report on the action regarding the governance arrangements for charitable funds. A new governing document is being developed via the Charitable Funds Group, and that will go to EMT, and then we'll arrange a meeting of the trustees following that. Have I reflected that fairly, Pete?
Spot on, Caroline.
Thank you so much. So that's just to update everybody on that. So thank you. Are there any other matters arising from the action log or the minutes that colleagues wish to raise? Brilliant. Thank you very much indeed. I am delighted that we have with us... Pardon? Sorry, what was that, Michelle?
I said no, nothing from me, Caroline.
Thank you, great. So I'm really delighted today that we have as part of our staff story our colleagues from Speech and Language Therapy. I think it's a little while back now, but I do remember there was a launch of the film, and a lot of good work was done around engaging, you know, everybody in this particular area, particularly around stammering. For children and supporting them, and it's been on our sites for some time to have you both, Siobhan and Rose, come here today and share a bit more about what's happening in your service area. So we're really delighted to have you, and we've got Justine here as well. Justine, lovely to see you again. I did see you at the awards on Friday night, didn't I? Yes, I did, in passing. Just check. Amongst all the glitter and everything else. So how are we going to do this? I know, Lynn, you're the lead. Do you want to, is Justine, you're going to introduce and then hand over to Siobhan and Rose? We're going to about 10 minutes and then 10 minutes questions and comments for board to find out more. Yeah, over to you.
Lynn, that's okay with you? Yeah, so thank you so much for inviting us here today. This is a small but mighty team, I think, that we really value in the division. Because I think as we've started to really understand the impact of being able to communicate and interact in a proficient way, it's made our speech and language therapists, really, really important to all that around child development and best start in life. So this is one little area of the service that, as you said, Caroline, a year ago was launched in Hull. I think it was in one of the civic halls, wasn't it? And it was a really lovely afternoon and Michelle attended. We've got some great pictures, and they've had such a lot of interest around this work. I think, as Siobhan and Anne will say, probably internationally as well, recognised. So I will end there and hand over to Siobhan and the team and say 10 minutes for the presentation and then time for questions.
Yeah, and I think we're going to have an extract of the video, aren't we, as well? And obviously for board members, we'll share the link for that if you want to see the full version. Over to Siobhan and Ruth, sorry.
Okay, just share the screen. Lovely, that's great. So thank you for inviting us to come and talk about our film, which we're very proud of. Ruth and I work with children who stammer and teenagers and their families. We provide a specialist comprehensive service for people who stammer. The reason it's important to understand this is that stammering is, there's not much coverage of stammering in speech and language therapy training. Most therapists only receive maybe a couple of lectures in their whole training, and very few have any clinical experience. So when you enter the profession, most therapists are not very confident working with this group of clients. And it requires a lot of postgraduate training and a lot of clinical time spent working with these children and teenagers in order to provide the kind of service that they need. So in order to understand why it was important to make our film, we need to understand the role that stigma plays in stammering. There is a societal expectation that speech should sound fluent. And this is evidenced by, films will edit out any disfluencies. People are discriminated for not being fluent. Ableism ensures that fluency is the standard by which speech is judged. Now, you can see from the slide here that the medical model of fixing the impairment cannot be appropriate for stammering because there is no cure for stammering. So we work very much with the social model of disability, whereby instead of fixing the impairment, we ensure that society accommodates differences. And it's important to challenge stigma, otherwise it won't change. And stigma does change over time. And our aim is for the stigma around stammering to be a thing of the past, and the focus on speaking fluently feeds into stigmatization and can lead to feelings of shame and humiliation. And you'll see the effect of that in the film when you see it.
So first of all, we need to think about what actually is stammering. And we in speech and language therapy use this iceberg analogy. So above the water, you can see what you and I would hear when somebody is getting stuck with their speech. So they may be repeating sounds, blocking on sounds, making sounds last too long. There's often physical tension you can see in the person's face. However, what we see is what we don't see is what's below the water. And that's the impact of, for that individual, that moment of involuntary loss of control of their speech mechanism and the feelings of embarrassment, shame, frustration. And that can lead to stigma for that person. And that is more dangerous for the individual because it's all those feelings that lead to that person feeling like they need to speak fluently, and the pressure on trying to do something that is actually neurologically almost impossible for them to do can lead them to hide their stammer, to feel like they, and when they do speak, there's even more struggle that we notice within their speech, which can ultimately affect their quality of their life. So when a child starts to stammer, as parents, our natural reaction is to fix our child, to make their stammering stop, to help your child to be functioning in a way that is like every other child. And that is normal as parents, that we want our children to be okay. But our perception of the fix comes from parent feeling that stammering is unacceptable, and that comes from this view of ableism and stammering. We know that children are impacted on how their parents view them, and they're profoundly influenced by their parents' view. And these seeds of self-stigma can be sown in early childhood. So the parents' best intentions to help their child overcome their stammer can lead to the child actually struggling even more. And our feedback from our focus groups feeds into what we know from research, that how parents react to their child's stammer has a key to how the child's stammer will persist in the future. And that can either be a positive or a negative impact in the long-term future.
So Ruth and I have dabbled in film production before. In 2017, we made a film called My Stammering Tap, which some of the board members may remember. This was a huge project, but it demonstrated that we could step out of our traditional NHS roles and produce something that was valuable, long-lasting, and had real impact for our clients. My Stammering Tap
to interrupt Siobhan and Ruth. On the slideshow, it's not moving forward. Are you able to just put it onto SlideShare so that it can show the right slide?
We stop sharing and doing it again then and see what it.
Yeah, if you put it up to, can you see from beginning?
Yeah, that's what we did.
Sorry, interrupting your flow. I just thought when you come to see the film, it won't show.
Thanks, Justine. I wasn't sure whether we were.
I didn't know either, but yeah,
we were moving or not. Oh, okay.
So can you see that?
Yeah, we can see that background one.
Is it moving now?
Stages of the project fundraising. Yeah.
All right. Okay. Okay. All right. Okay. Sorry about that.
Okay.
So My Stammering Tap, which was the first film we made, is now an established resource for therapists both nationally and internationally, and it forms part of the care pathway for other services to support children who stammer. And because we invested time in developing links with the wider stammering community, we were able to build on this network for our next film, and we were hopeful that we could produce something of similar quality for parents. So we had to raise funds, first of all. So we applied for grants and we wrote to local companies for sponsorship. Action for Stammering Children helped us with this process. Animation is not cheap. We needed to raise £3,500 for the actual film and a further £3,000 to ensure that it reached a really wide audience and had some impact. So the research shows that the concealment of stammering due to stigmatisation can start at a very young age and can be unintentionally reinforced by significant people in children's lives. And this was borne out by the testimonies of our focus group. We invited adults who stammer and parents to share their experiences in several workshops led by Peter Snelling, who you can see on the screen there. And we're also pleased that Peter's been involved in the new website for Children's Services, so his work is excellent. The focus group met on several occasions via Teams. This was just after COVID, so we were all used to meeting remotely. But this enabled us to include participants from all over the country and from America as well. And Peter used their testimonies to generate visual imagery for the film. We'd worked with Peter on our first film, so we knew we were in safe hands. His ability to crystallise complex messages into memorable, emotionally engaging animation, which would be future-proof, was crucial to the success of the film.
So for publicity, we were very fortunate that we got Sally Fairfax from Radio Humberside. She did a special feature on her radio show about the film. We also had ITV Calendar News. They covered the launch event, which was held at Hull Minster. We had a keynote speech from Nick Hewer from Apprentice fame, but he's also the president of the Royal College of Speech and Language Therapists. And we also got an introduction video from Michael Palin. The launch event, it was really important for us that we created a buzz around the film, so we reached a wide audience. And it wasn't just something that we made for ourselves. And it was humbling that in the age of online attendance, people travelled to attend the launch at Hull Minster. It was attended by over 100 people, including politicians, councillors, the Lord Mayor of Hull, the Chief Executive of our Trust, speech and language therapists, as well as representatives of the stammering charities across the country. We also had our sponsors, so that was local businesses who also attended. Many children and their families who were on our caseload, who helped make the film, also attended. The launch event was live streamed, and we had 600 additional people throughout the UK and internationally attend the launch event. So the film, since it has been launched, has had over 11,000 views on YouTube. It is featured prominently on our national stammering charities websites, and it's used by therapists across the UK and abroad to support children in their work with the therapist. It's integrated into our care pathway here in Humber, and we know it's integrated within other speech and language therapy services across the country.
So before we watch the film, we would like to take this opportunity just to highlight our hopes for the future and to make you aware of some of the challenges we face. To do work like this requires a lot of dedication and clinical time. So while we're really proud of what we've achieved, we want our future to look just as bright.
So we would like to think we could continue to provide nationally recognised specialist stammering service. We are recognised as a gold standard service within Humber. To continue to be able to raise awareness and reduce stigma about stammering. Recently, we were in St Stephen's on National Stammering Awareness Day doing an event with the children from our support group, and we'd like to be able to feel we could continue to do these type of events. We'd like to be able to increase the opportunities to celebrate stuttering, identity and pride. And we'd like to increase the opportunities that we can provide for group therapy within the Trust for our children and their parents.
Okay, so the challenges that we face at the moment, obviously, as I've mentioned, therapists need specialist training and a lot of clinical experience to work with this group of clients. We know that budgets are quite limited and budgets for training, and there is pressure on managers to divert clinical time to other parts of the service where there are pressure points and long waiting lists. And this has already resulted in a loss of some clinical time from the stammering service. So following Ruth's retirement and return and another member of the team leaving, we've lost 2 days a week of clinical time, which is beginning to have an impact. So in order to continue the good work that we've done and to keep providing the service that we want to, we feel that this needs to be acknowledged. So without further ado, we'll watch the film and see what you think.
Imagine your child who you thought was perfect develops a problem under their surface.
The film.
That one day you're
hearing
thinking
the sound.
Oh dear.
Another go.
See that?
No, just the noise.
imagine
just the
your
sound.
child.
Worked perfectly when we ran through.
Always the way.
If you go on to click that on, so we've got, so not share window, did you say sharing screen instead, right?
Try again. This might do
who
it.
you thought was perfect
we're off.
develops a problem under their surface. That one day you're thinking that everything's fine, and then the next you are worrying all of the time.
How will my daughter ever belong when there's this thing in her now that's gone terribly wrong? How will my son get a job, find a wife? How will they make their way in this life?
The thing that was wrong with me, I'd like to share, was not that I'm green with long purple hair, was not that I had a beard aged just 3, or a giant banana where my nose ought to be.
No, we went to a man with a good bedside manner who told us your child developed a stammer. My mum looked at him, she gulped and she wept. She said this is something that's hard to accept.
My dad said to me, we want to assure you that we will not rest until someone has cured you. We promise you now this is only a stage. There are things they can do in this day and age. Fluency targets, try tapping your leg. Try to empty out every thought in your head. Has this thing developed or is it from birth? Could you pop on these headphones like Colin Firth?
And each cure that was offered just made me feel worse. My so-called affliction, my terrible curse, the pressure to change, to be fluent, to win, just made me feel shameful and broken within. And shame, it can grow, it can feed on your soul, it can worm its way into you, dig out a hole. It can take things from you, your light and your smile, can make the world seem like it's cruel and hostile.
I knew how they felt, could see in their eyes, the disappointment they tried to disguise. It was all that I was, it was all that I'd be. A stammer, no fluency. But then I grew older, moved out, found some mates, got a job, went abroad, bought a flat, went on dates, fell in love, found myself, had a child, made a home, and twice a week called my folks on the phone. They hadn't meant harm with the things that they'd spoken. They just tried to fix me when I wasn't broken. They looked at a child and saw what was wrong. They could have instead seen what was strong.
If you can accept and make room for their speech, they will believe a good life is in reach.
If there's something that helps, ask them to say. Ask what you're doing that gets in their way. Be patient, just chat. Enjoy it, have fun. They're different, that's fine. You're their dad, you're their mum.
Fantastic. Great.
So-
Ruth?
Are
you
you on
want to
mute?
just-
Ruth?
You're on mute, Ruth. Do you want to just speak? We'll go to some questions and comments if you just wanted to add anything more after that, because that was brilliant.
So we were just going to say any questions.
Oh, right. Okay. Thank you. That was great. It was really good to see. And I've met Peter Snelling actually at the launch of the One Stop website for all children's services and working in partnership with others. He's a really incredible guy. It was really interesting hearing about his thought processes and his engagement in making these films for us. So he's a great guy to work with. Questions, comments from colleagues. Priyanka.
Thank you for the film and the presentation, and I can see that you've been very creative in gaining publicity for the work that you have done. That's really important, however good your work is. You know, if you don't get it through to a lot of people, then the value sort of goes down. But my question is, you know, numbers wise, do you know how many people that you get to work with, and children who, it's mainly children, isn't it, that you're working with? And if that's so, what are the numbers like?
Yeah, so we work with children from 2 right up to 18, 19, and our average caseloads are about 170. We've usually got around that number, and we get on average about 12 referrals a month. So yeah, so I don't know what the entire
percentage of the population. It's about 5% of the speech and language therapy population, the speech and language therapy service. So it's small. So 8% of children stammer. So we're talking quite a lot of children out there that potentially might be referred to our service. And what we know actually is if you offer a specialist service within an area, you maximise on the referrals because people know about those children and they refer to the service. So our referral rate has been pretty stable actually for the last, it went up during COVID, but it's stabilised for the last 2 or 3 years.
Thanks, thank you.
Thank you.
Dean?
Yeah, thank you. Thank you for the presentation, and you'll see there's some lovely comments in the chat for you as well. And it just goes to show, doesn't it, what NHS staff can do when given, you know, the right culture and some permission and freedom to be creative and innovative. So it's really wonderful to see. So thank you very much for that. I wonder if you could just say just a little bit more about the medical model. How sort of prevalent is that, and the sort of evidence around it, or direction of travel around that as well? Is that okay?
Yes, so the medical model would suggest that the individual has got to do something to fix their problem, and that fluency is the aim. And you will see in society there are lots of claims of cures for stammering, and in mainstream media there's lots of celebration when someone apparently overcomes their stammer. And when people talk about overcoming stammering, they're talking about being fluent. So that's the influence of the medical models, that somehow you've got to do something to not stammer and to be fluent. And although there are techniques that you can learn to produce fluent speech, for someone who has a stammer, that fluency is very effortful, and it's not natural fluency like you and I would have, where we don't need to think about our speech. So it's not a cure. So the social model, which is the way that we work, is around reducing that stigma, trying to get rid of that stigma, and helping the general public understand that there's nothing wrong with stammering. Stammering is for some people it's an identity, and it's something to be proud of, and it's beautiful. There's beauty in stammering, and there are lots of gains from having people who stammer. And certainly from employers' point of view, if you have someone who stammers, you will already know that this person has great resilience, because growing up with a stammer is hard. This person has great empathy, because you know that when you grow up and you're unable to say your name, you develop a lot of empathy for people. So there are lots of real qualities to be celebrated in stammering. So the idea of the medical model trying to eliminate stammering for us is not the way to go.
However, for young children, that there is a slight difference with young children. So young children, as the nervous system is developing and the myelination hasn't happened, the sort of hardwiring of the nervous system hasn't happened up until the age of 7, there is a lot we can be doing within therapy to enable those neuropathways to establish, which may end up creating fluency for young children, which is why, so it's a bit of a conflict really. But for young children, we are looking at helping those neuropathways establish, helping parents do the things that will encourage that development, to hopefully for those young children, we know 75% of that 8% that get referred, the problem can resolve. And so we are part of that process too.
Thank you. Stuart?
Yeah, morning. I'm really enjoying listening to your expertise. As a non-expert, if I come across someone with a stammer, what's the best thing I can do, and equally the worst thing I can do in talking with them?
Okay, so
Good question.
yeah, and in fact, you know, this is one of the problems, is that because we don't often meet people who stammer, well, you probably do meet people who stammer, but they're doing their utmost not to stammer in front of you. So you may not know they have a stammer. But if someone is stammering, the best advice is to just listen as you would listen to anyone else. So maintaining natural eye contact, focusing on what they're talking about and not how they're talking, and extending the same, you know, using the same listening skills that you would use to anybody, giving them space and time to finish what they want to say. And yeah,
Sorry to interrupt.
that's it.
If you watch My Stammering Tap, our first film, actually that was our children and again in our support group that actually fed information to Peter about what they wanted people to do when they were listening to them. So if you watch My Stammering Tap, that actually encompasses all the things we're talking about.
Thank you very much indeed. I enjoyed the ukulele background, by the way, the music.
He plays the ukulele. He plays the ukulele. If you need someone for the next animation, Stuart's your person on the ukulele. We'll share both links. I think they should be on the website anyway for Humber as well. But we'll share the links for the previous film and this one. Michelle.
Yeah, good morning and thank you. And your passion just oozes out, and the differences that you're making. And I remember the evening really well, because just the mood in the room was fantastic, and speaking to some of the young folk as well. So thank you for that. And the film, I never tire of seeing it. It's an absolutely fantastic film. And as I say, your passion oozes, and you really are making a difference. So thank you. And you are a very small team. So let's be aware that it's not a huge amount of resource, but the differences that you've made on the connections, I think, are just amazing. And what I would say for me, it's about how are we continuing, and this is mainly for us to take away, and James to take away particularly, is how are we publicising the film, not to increase the 170 that you've got on your case unless we need to do that and reach out, but also just to support and to inform and looking at Justine, really support our other colleagues and staff that work with children and young people that maybe not aware of the service, maybe not aware of some of the questions, that the one that just answered in relationship to Stuart. So just to support them on that. So I was wondering, how are we and can we engage in circulating and use it as an educational tool? Now, apologies if we are, but I think if we're not, we need to start to include that, because it's really powerful.
Yeah, absolutely. We'll take care of that, Michelle. Yeah, it's spot on, actually, because that's the point we were making right at the beginning, wasn't it? That these are the antecedents of later mental health and a child's ability to develop and reach the potential. So yes, we will. We'll take that away, and we'll certainly share this wide. I think we did do some initial sharing, but you say year on, we maybe do need to revisit that and the impact of this learning across the trust and definitely across the division, because I know the health visitors, as 0 to 19 services, they work so closely with the speech and language, and I know they will often come to you to ask about things like stammering. What do we do? Just as Dean's asked those similar questions. So we will get that learning out and shared widely.
And can we share it wider maybe with the ICB as well? Because I think obviously we do a lot of work with children and young people across the ICB, so it's a useful tool that's there. So if they've not got it, and if they have, then it's fine. We can just keep circulating it, because it's really powerful.
And it's something that we could hang on, couldn't we, around the development of speech and language in children anyway, because that's a really good marker of their long-term potential and educational outcomes as well. So could badge it all up together.
I mean, another great thing about the video, from what I've just seen of it, it doesn't date. There's nothing in it that you couldn't use it in another year and so on. Thank you so much. I just had one question, because I understand that boys are 2 to 3 times more likely to develop a stammer than girls. And is that right? Have you got any reflections on that? And of course, in the film, it was boys' voices. I just was interested in that. Is it because we're underrepresenting the voice of girls in this area, or is it actually a thing?
No, the research suggests it's 4 boys to every 1 girl, and that is probably down to the neurological development. So obviously it's gross generalisation, but it seems that in speech and language therapy, girls are more proficient at developing speech and language early on. Boys are better at motor skills, and early on. So we have more boys in clinic generally, not just for stammering.
I think there's also, it's not quite clear as well, because women and girls tend to mask better. And there is, we haven't talked about it in the film, but there is a thing called covert stammering, where someone is on the surface sounds fluent, but maybe working really, really hard under the surface, doing all sorts of tricks and things to hide their stammer. So there may well be more women
Adults
in an adulthood.
Children,
Yeah,
it's definitely
children,
it's 4 to 1.
So it's an interesting area.
Thanks very much. I think it's just interesting in terms of equality. It's just this sort of gender differences that happen. Thank you so much. I can't see anybody else's hands up, but thanks for your time this morning, Siobhan and Ruth, and of course Justin. And I look forward to getting the links and seeing them and sharing with other people I know, including my sister-in-law, who's a retired speech and language therapist in North Yorkshire. So yeah,
we might know her.
I'll try. You might know her, but that's for another conversation. But anyway, thanks very much indeed, and have a great rest of the week. Thank you.
Thank you.
Thank you.
Okay, that's great. Fine, we'll move on to my report. It's all in there. Any comments welcome. Just to say, can I just say congratulations to Fran Ashton, who recently won the Mental Health Social Worker of the Year. Thanks to everybody who made Friday's Staff Awards a fantastic event. All those who came along. I think we had nearly 60 nominations that came in. I'm glad I didn't have to judge all those categories. It must have been really hard. Thank you to board members who took part in that. And thanks to governors who came along as well on the night. Congratulations to our communications team who did this year receive a Michelle Amine Special Achievement Award for all the work they do. And actually, you know, the last item, again, working with our staff, the comms team are very involved in helping support animations and other forms of communications as well. But it was a great night, and it was a great just to have a chance to have in a relaxing way, hear more about the depth and range of different services we're providing and some of the fantastic things that's going on. So yeah, why don't we give everybody who took part a board round of applause virtually for all their efforts. It was really great. Brilliant. Thanks very much, everyone. Anything else on my report that people would like to ask me about? No, great. Thank you very much. We'll move on to Michelle.
Thanks, Carol. You've raised your hand, I think, Caroline. I don't know if that was...
Oh, sorry. That was meant to be raising my hand to clap. Sorry.
No,
forget about that. Ignore it. It's fine.
Well, you picked up a couple of the bits I was going to raise, which was about Fran. And obviously I was going to say absolutely fantastic evening on Friday, and I think about 260 people there. Thought the venue was great, a lot more space on the venue. So obviously we'll do the usual feedback from staff in relationship to that. But I certainly left everybody dancing on the dance floor. So that was always a good sign as well. So, but congratulations to everybody for making it a really success, and more importantly, congratulations to staff, because they are truly amazing. Going on to my report, I'm not going to touch on the national work, so we'll pick that up a bit later in the agenda. So just the general things, I will take it as read. There are 5 policies there to ratify. The visibility continues across the executive team, and actually I've had some really positive feedback from staff saying that we are probably one of the new member of staff saying that we're probably one of the most visible executive committees and boards that they've seen, but particularly exec. So that's come up from a couple of separate people, and it was mentioned quite a bit on Friday night as well. But we'll continue that visibility across the organisation, and there's some feedback in the reports. We are going to support our staff in relationship to Christmas presents. There's quite a large Christmas agenda, so I'm not going to go through that here. It has been circulated. We will be doing a countdown to Christmas, bit of an advent calendar where there'll be some surprises in there. But we are going to give ourselves a little treat this year of £5. We did ask staff what they wanted us to do. It's only a small token just to say thank you for all the work that they've done. We will pay the tax on that. I think given the financial positions of the ICB, I think it's a really good, it's good, and I think we get some really good feedback for staff. The staff survey is in its last week. I'm sure Karen will pick that up in a little while when I bring Karen in. The response rate is just slightly lower than last week. I'm sure Karen will have the up-to-date, last year, the up-to-date figures on that. And our flu campaign obviously continues. Lots of things happening in relationship to the ICB, partly around urgent care and finance, but we're working very closely with the Integrated Care Board on both of those aspects, and we will continue to pick those up in the relevant subcommittees. Around the system, the chief exec meeting has been redesigned. It used to be a whole system meeting on a Friday. It's now gone to specifically trust chief executive. I think Stephen is trying to look at the size of the ICB board, but also that decision making within the ICB. There are two consultations out. One is the ICB consultation in relationship to health and wellbeing for the population that it serves, that we are supporting. But obviously there's a national consultation, which are the 5 questions that the NHS is posing. As an organisation, we are responding to that. It has been circulated to non-execs. If you could let us have any headlines by close of play tomorrow. Pete is the lead for that. We're putting it together and it has to be submitted by Friday, and we will correlate all the responses that we get, or Pete will, and we'll send it in and we'll circulate it to the executive team. Really good that we've got the new maternal mental health service. I don't know if Hilary wants to pick a bit of that up. And I'm sure Kwame will mention the research. This is really cutting edge. £11 million has been given for the work in addictions for addiction services. Now, that is an amazing amount of money, and we are really privileged to be part of that as well. And I thank everybody that's enabled that to happen. It's been ongoing for quite a while now, but it has actually formally been endorsed and announced. A bit in there around the psychology update, which I think is really important. And again, a little bit about the mental health bill that Caroline alluded to. It's going through Parliament at the moment. We are working quite closely with some of that. We've been aware of it for a while and actually influenced parts of it as well. It was Freedom to Speak Up month. Obviously, the board had lunch with the Freedom to Speak Up ambassadors. That's been very successful. We are doing an evaluation of that and we'll circulate that to the board. I think that's about it, unless any of my colleagues want to bring anything in. I'll bring Karen in just to maybe give us a very quick update on the staff survey. I've already put your hand up, Karen. I was going to bring you in, that's okay. And some of the work that we're doing in our postgraduate scheme, but I think we're really proud of, because we're probably the only organisation in the country that has its own postgraduate scheme for people that have gone through Proud and then our alumni. So, we opened that, which was really good. But I'll pass on to Karen and then any questions, Chair, if that's okay.
Yes, so quick overview on the staff survey. So it's been an exciting few weeks. I know particularly in EMT, we do look forward to the Friday report. So we are levelling with our response rate last year. So on Friday, we were at 52% or thereabouts. And we did complete at 55% last year. So like I say, we were level at that point last Friday. So last push this week, I know the comms team have upped the ante, as it were. We will be sharing again the incentive arrangements, because there is an iPhone and an iPad up for grabs that will be selected person who has completed via IQVIA. So that is quite exciting. So we'll have the final response rate probably actually on Monday or Tuesday next week, but we'll have a decent indication on Friday, at which point it normally takes a few weeks before that raw data starts to come out. So it will maybe be sort of towards Christmas, maybe early January, where we'll have a better indication of actually what the results will tell us. Thank you.
Thanks, Karen. I see a number of hands up. Priyanka.
Good morning, Michelle. The question is for you. When I was reading your report, I saw that there was a new policy you mentioned about mixed sex accommodation. So it sort of brought to my head what I had heard on the news, that some staff were taking their trust to court regarding transgender. This was regarding staff, but do we have any policies in place for staff or for patients, how we treat or manage transgender issues?
I'll bring Karen in first from the staff element, and then I'll bring Hilary in from the patient end, if that's okay, Priyanka. So Karen?
Thank you.
Yes, so we have we did have two policies, so the overarching EDI policy and then a separate transitioning at work policy, which addressed some of the concerns that you raised. What we did in the last 12 months or so, from memory, is that we actually combined the transitioning at work policy into the EDI policy, so that all of our sort of inclusion initiative support, etc., was in one place. So the answer is absolutely yes. What we also have is the LGBTQ plus staff network, which is a really good platform for us to be able to openly nurture those discussions when people are having difficulties, and make sure that we're addressing concerns appropriately.
I think it's also the concerns of cisgender women, isn't it, as well, around changing rooms, and that's the Darlington situation.
Yes.
I presume we're listening to that as well.
Yeah, of course we are, yeah. And that's one of the things that we're constantly looking at across the division, and then LGBT plus and other networks as well. Hilary, do you want to mention a little bit about where we're up to from a service user patient point of view?
Yes, we've got policies in place for and transgender inpatients. I mean, Kwame may want to say more in a minute because he leads on that. But in the eliminating mixed sex accommodation, you can see that we went out for consultation with those groups as well, and there's a section in there as well around care of transgender patients. But I don't know, Kwame, it's whether or not you want to say anything more from your perspective.
Yeah, no, I think that we have a policy which was widely consulted, which we use the Trust Transgender Network and LGBTQ plus network. We did also consult with Leeds Gender Identity Clinic, and we had opportunity for some of our nets, as I remember, David contributing as well. So our policy is one of the leading ones in the NHS, and a few organizations have actually tried to look at what we've done. So if you want to see it, I'm happy to share what we did it on the intranet with you.
The mixed sex ward situation is primarily, though, isn't it, about men and women who are born as men and women ending up on mixed sex wards, isn't it?
Yeah.
And about some, and it's had an impact on our out of area placements, I think, as well. Some of this, hasn't it, in terms of finding suitable accommodation?
It has. It's quite
just to be clear, I think.
Yeah, I mean, there's two aspects. Obviously, the transgender is something that we're working on and very sensitive and very conscious, because as the chair said, it's also about women in that wider environment as well. So we are very sensitive, and we do consult a lot, and we do constantly keep looking at our procedures, etc. But the mixed sex accommodation came in several years ago, and this was about making sure that that males and females weren't on the same ward, especially when they were open wards. So it was geared more to acute sector, particularly, or if people were in dormitories. Now, obviously, we don't have dormitories, but there is something about crossing over paths if you're going to bathrooms as well, and there's quite regulated regulations, and including all sorts of different things that organisations can get and have, as it were. But and that has led to out of area placements, because if you haven't got a female bed, then you've had to send them out of area. But we've got some flexibility within the way our units are constructed, so we can change sides from males to female and female to male. So we are trying to be quite flexible, but within that regulation. It's just an update of the policy.
Yeah. There's a lot of work done. There's a lot of work been done in this space. Okay, Phil.
Yeah. Michelle, just welcome the new expanded maternal mental health service. Do we have a view of how that will look like? That's one question. And the second is, I'm increasingly exercised by people with mental health issues, what happens when with the waiting to be seen, and just a bit of reassurance that some of the criteria, like referrals, long be considered accepted 3 months following the loss, to allow time for the natural grieving process to occur. It's not a sort of fixed time issue, and I just wanted a reassurance that those things are guidelines, not fixed sort of times. It's good to have some criteria, but it's also realise that individuals are individuals.
Indeed, and we do have to have guidelines, and obviously we are. I do think as an organisation, hopefully very receptive and very flexible in how we utilise those, and we are constantly looking at service users on waiting lists in relationship to their care, and a lot of them actually on the waiting list are actually known to our services and are part of our services elsewhere. They're waiting for another aspect of their care programme or their care plan, as it were. And one of the things obviously Quality Committee should be aware of, being chair, Philip, is that's part of one of the things that we're really into the Quality Committee looking at. But I'll bring Lynn in. I'll also bring Lynn in about the maternal mental health service, because it is something that's really important and something that we are developing in and amongst all the financial constraints that we've had as a system as well. Not from an organisational point of view, and we are the lead organisation, which is really positive, and it builds on the current services that we've had and that we do deliver. But Lynn, could you want to?
Well, Michelle, you've gone on mute.
I know, it just turned me on mute.
It wasn't. I didn't do that. I promise. I didn't do that.
Well, I didn't do it either. But well, that's quite interesting. A lot of people do want to be me now and again from time to time. Anyway, what I was saying is, I'll bring Lynn in just to maybe expand on those, if that's okay. So, Lynn, I don't know if you want to expand on both of those aspects. Good morning.
Yes, thank you, and they're really good questions, Phil, as well. So. We are delighted to have finally, because we've been seeking this for some while, to have had confirmation of the funding for this service. 2 years ago, we did have a time-limited non-recurrent resource that didn't cover the whole of our ICS area. So we are really pleased that it is now, but it is finite funding, Phil, as well. So there are some limitations to the service. They are following national guidance, so criteria that has been sort of set down. But obviously we want to provide as comprehensive a service that we can. We are providing it alongside our perinatal service. So we've got an enormous amount of expertise in that service around maternal and mental health as well. But we are going to be providing it as the lead provider across the whole of the geography. So that does limit it a little bit, Phil, but obviously within the resource that we've got, absolutely we will maximise the impact of that. Obviously we'll be constantly reviewing the outcomes of this service as it gets established as well. So our intention is we're already starting the mobilisation. We hope to have the service up and running as best as we're able to, obviously towards the end of Q4 as soon as we can, certainly by the beginning of Q1 next year. And Phil, obviously I'll bring some further updates to the Quality Committee as we start to sort of get the outcomes from this work alongside sort of perinatal work that we're currently doing. But we're absolutely delighted. And we'll obviously be working with colleagues across the other mental health trusts to support and provide the service. But we'll constantly look at the criteria for the reasons that you say.
Thank you, Lynn.
Thanks, Lynn. And they were great. And congratulations to all our staff in the perinatal team, because I met with them earlier this year and had a bit of a chat with them in their offices. And I know they were really excited about this, but also excited about that broader definition of maternal mental health as a title as well. And so I'm sure they're really pleased and they're doing great work. Stuart.
Yeah, thanks. A question about another section of the report. Will you take those now?
Yeah.
Yeah. So Hilary, I think it's for you. Just a clarification on the primary care patient safety strategy piece. So it looks like you're doing some work with our primary care practices in response to that initiative. I just want to understand that it says there that nationally the areas identified as areas of avoidable harm are diagnosis 61%. So does this mean if something occurs and is reported, then about 2/3 of those cases, 60%, are to do with a misdiagnosis? Is that what the research is saying?
We haven't got anything contextual behind those figures, Stuart, but I would have read it the same way that you have. Obviously, it's on a national picture. So what we're doing at the moment is doing a bit of a baseline with our own practices. So we've got fairly good reporting. I think we benchmark very well with our practices against others, against incidents. So we get about 200 a year reported through from primary care. I'm quite sure that is by no means the entirety of it, and that's where a lot of the work will be going on, is trying to maximise that learning. But the work that's going on at the moment is looking at the current reporting that they've got and looking at what they are reporting and maybe what they don't think they need to report, which maybe they should be.
Yes.
But also looking at against these 3 areas as well to see how we marry up against there. So it's a bit of a baseline piece of work at the moment that will then inform how it goes forward for those 3 practices.
Yeah, thank you. Sounds good. Thank you.
Thanks very much, Stuart. Kwame.
Yes, thank you. I wanted to bring to the attention of the board of this groundbreaking joint partnership between us and Hull University on and setting up mental health and addiction research in Hull. I mean, this is a £11 million over 5 years research funding, which we are all very, very delighted. It's the World Cup best secret. We've known about it for some time, but the embargo was released only in October. There will be a formal launch, but we are already doing work and behind the scene. 2 of our staff are also received grants as part of it. And as part of it, we are also looking at appointment of a joint clinical and academic professor of psychiatry and addiction as well. So we're really, really delighted about this. We've always known that Newcastle, Leeds and York have disproportionately more research into mental health than we have. And this will go a long way to address the imbalance. And so this is to bring to the attention of the board. Thank you very much, Caroline.
Fantastic news. And, it's really great to see those 2 areas being brought together even more as well, addictions and mental health. So congratulations to everyone on the team who's played a part in this. And it'll be very interesting to keep us informed about, when the launch is and how the work's progressing. I'm sure it'll be something, some of the committees that we have, we'll also want to have a look at and hear more about. Fantastic. Well done. Brilliant. Nobody and no more hands up. So thank you, Michelle and colleagues on the executive management team for your reports today. And we'll move on to publications and highlights reports, Michelle.
Sorry, can we just ratify the policies, Caroline?
Oh, apologies. Thank you very much. Too quick. Right, let's ratify the policies. Let's go through each one. Is the board happy to ratify the policy for eliminating mixed sex accommodation? Yes. Secondment policy. Thumbs up. Thank you. Emergency preparedness, resilience and response arrangements, EPRR. Perfect. Rostering and inpatient search policy. Right. Okay, brilliant. They are all ratified. Over to you, Michelle.
He's done it again. Just the normal policy, the normal publications document with the policies and procedures in there, and the relevant comments by the relevant director, how we're going to deal with that within the organisation. Again, I'll just open it up to questions, Chair.
Any questions on those? They're really helpful having the lead EMT members' comments. I find that really helpful. They're there to look at it at your leisure. Okay, no comments. Right. Thank you. We move on then to item number 10. Paul, sorry for keeping you waiting. Thanks for being with us. And I'll hand over to Paul, I think, directly. Is that okay? Unless there's a... Fine. Paul, thank you.
Thanks very much, everybody. I'll take it as the paper as read. The purpose of the report is to provide an update in relation to the outcome of the intensive and assertive community mental health treatment review in the ICB following the incident in Knox Healthcare. The trust action plan has been circulated to everybody, and we were continuing to report progress through EMT and the Quality Committee. As you'll see from the information that's coming out from NHS England at a rapid pace, so there's things coming out all of the time, and production is in place of new national guidance, which will be coming out probably the beginning of next year, and also work from the CQC to develop national quality standards, which we are well linked in with from the trust, and particularly with our lead for this, our clinical lead, Lynette Robinson, who also works within the ICB and also works within the NHSE regional team around this area. In the meantime, while we're waiting for further guidance, as you will see, we're working through our action plan and we're addressing the areas that we've identified for improvement. We have been asked to give us some indicative costings of what services would need to look like in the future, which is very difficult when we don't know at this moment in time. But we are working through the ICB to produce this. But the message is still clear. There is no new money for any service developments at this moment in time. The board are asked if you can note the outcomes of the review and the responses that we have taken as a trust to ensure not only compliance but also delivering the trust action plan. I'm happy to take any questions.
Thank you very much, Paul. Over to board. Stuart.
Hi, Paul. Thanks for the report. Very clear. On the question of resources, then, so you're thinking about developing or putting together a proposal for what an enhanced service might look like. I guess it's an open question for us as a board. I guess in due course, if we believe that we need to do something different or do more of something we're not doing, and yet there are no new resources, we'll need to take a view at some stage about reprioritising from existing resources. How will we do that? What's the time scale? Is that setting the what year are we in? Will that be setting the 25-26 budget?
Okay. I think the first thing to say is that although we are asked to give an indication of what costs would be, we are looking at this at this particular time that there is no money, because if we start to look at what that would look like at this point, I think we might be disappointed. Yes. And I think actually what we've identified through the action plan and through our review, that there are things that we can do to enhance the service that we provide. Yes. With some changes that will not have that bigger impact on from a financial perspective.
Understood. That's really helpful. Thank you. So doing things a bit different, having an eye to other things that we're currently not focusing on is the answer, I think.
Yeah, and I think it's building upon some of the things that we already do. It's taking that to that next level. It's working with our staff, with our service users and our families, looking at what would the changes make that would make a difference.
Thanks very much indeed. Really helpful. Thank you.
Thank you, Stuart. Dean.
Yeah, thank you. Just to agree with Stuart, really thank you once again, Paul, for the paper, and also to say, given the particularly tragic consequences, and background to this case, just the sensitive way that you've approached this, both at the annual general meeting and in the updates that you've done. And I think it's excellent, really, that we're trying to just keep on top of the developing picture, recognising it's moving at pace. It's really helpful for a board, I think, to see how we're responding to that as it comes out. And no doubt, as Stuart was alluding to, as further planning guidance comes out this year, we'll be able to sort of identify some of the costs and resources associated with that as well. But really, it's just really reassuring about the grip that we seem to have around this in looking at the consequences that there may be. So thank you to you and the team.
Thanks, Dean.
Thank you, Dean. Steph?
Thank you. Thanks for the report. Just a couple of things. First of all, just to welcome the establishment of a group looking at CTOs. I think it's an area where, as a Mental Health Legis Committee, we're noting the numbers of CTOs that we have without a real handle on direction of travel, of whether we should be using them more, we should be using them differently, how we should be using them as an organisation. So that's a really welcome development. More broadly, though, I think in the absence of NHS England guidance or prescription on what the best practice should be, obviously at this point in time we're seeking to optimise what we can do within the resources that we do have. Just you've mentioned sort of early next year for NHSE to publish some guidance. Do we anticipate what that might look like, and how prescriptive it might be as an organisation? And the reason I say that is that in a sense, in terms of risk management, it provides some protection for the organisation, in that if we follow the guidance, it sort of demonstrates that we're meeting that best practice. Do you see what I mean?
Yeah, I do. I think firstly is how are we aware? Do we know? Can we predict what's going to be in that guidance? I think probably the answer to that is we have a good idea of what will be in that guidance. We know what quality standards there are around delivering an assertive approach that we would see, then maybe not be written down, but as clinicians and as working with our service users and what service users are saying to us, we pretty much know the areas where we need to concentrate on, which we are predicting will be in the guidance. We also, as I mentioned, with people like Lynette, who we're very fortunate to have within our service, is also linked in to that guidance. We also know from the CQC quality standards, we've already been involved in a workshop that was held a couple of weeks ago, a regional workshop with CQC and NHS England, to look at what those gold standards would be. So the more that we can link in and influence and support those standards, the more we're going to be able to meet them. How prescriptive they're going to be, that's something yet to kind of fully understand. Does that answer your question?
Yeah, thanks, Paul. That's really helpful, and I think you're right. It's that staying linked in at this point, isn't it, and making sure that whatever modifications we make as an organisation, that they line up with where we think the thinking is at the moment, and that we don't just wait. That's brilliant. Thank you.
Absolutely not. And the more that we listen and link in and co-produce with our service users and our families, we can't go far wrong.
Yeah. Thanks, Paul.
Great. Phil.
Yeah, it's just a point around sort of no wrong door. I really welcome this. As you get more discrete services and we have efficiency targets, there's a danger of sort of triage into criteria. It's a bit similar point to previously. And I think one of the things that all services need to do better is more intelligent, person-centered front ends. One of the frustrations when you're out in primary care looking into a mental health trust is the knockbacks all the time, that it's not appropriate for this service. And you could just say something briefly about how we get to a place where we accept somebody's got a problem and that it's not, but there's no wrong door. But how we get people into the right services or the right help, it might not be a service.
I think you hit the nail on the head, Bill, when you said about person-centered care. This is all about person-centered care and trying to put the person at the centre of what we do. And you're right, this can get quite complicated when we have lots of discrete little teams. And this is what we'll be doing in this area, is building upon the work that we've already done with the CMHT transformation, is trying to ensure that when somebody comes into our service, that if it comes into a place where we might not be best suited to meet that person's need, we have them conversations with the individual, we put them at the centre, and we sort out where that person goes and support the person to get to the right place, whether that's within our service or outside of our service. We don't send that person round the houses or to different services to try and get in. And that's the principle of the no wrong front door that we're trying to achieve. We actually held the workshop, as you can see, you'll see as part of the report. We'd actually hold our first workshop yesterday, and this was something that was quite clearly coming from all of the people within that group. Is that what we don't want to do? Is to create another front door, to create another set of criteria for people to meet to come into our service. But what we do want is to be able to step people up and step people down at the right time that meets their needs, and that's the area that we're concentrating on.
Thanks, Paul. That's great.
That's lovely. Okay. I can't see any other hands up. So, Paul, thank you so much. It's really helpful just having these updates and really helpful questions from colleagues as well, and reassuring. Thank you so much for your time today.
Thank you very much, everyone.
Thanks, Paul.
Okay, we'll move on to item number 11. I think we've got Sarah with us on the Health Inequality Strategic Development Timeline. Sarah, there is avatars there. That's nice.
I'm here now in person. So thanks for taking the time to take this item. I'll take the paper as read, but just to say we're now underway with developing a health and equality strategy. It's provisionally called a strategy for want of a better word. It's more of a document that sets out how our approach to addressing health and equality supports delivery of our trust strategy. But that's a little bit long for a title, so it might become a health and equalities plan as we go forward, recognising what we do in the health and strategy. A what?
Health Inequalities Plan, a HIP.
Oh, there we go. That'll do. That's nice. It's got a nice acronym. So we've started moving forward. We've produced a first draft, and we're starting some consultation with staff. It is very much aligned to the trust strategy, and we'll build on the work that we've done so far on health inequalities. I think the aim today is just to get approval for moving ahead with that approach and with the agreed timeline. We're aiming to come back to board in March, recognising that might be quite tight, and we're just keen to understand how we can engage you in this process.
Thanks very much, Sarah. Any questions from board? Steph?
Yeah, thank you for the report. Yeah, just a couple of queries. One is about geography, and the other one is about the mixed nature of our population, if you like. So will the plan or strategy cover East Yorkshire, Humber, North Yorkshire, the whole patch, as it were, wherever we work? And secondly, obviously we have very mixed communities. We have huge rural community, expanses of rural community. We have pockets of deprivation and inequality. And I was just reading a report from the North Yorkshire Director of Public Health this week about the mortality rates in some of our coastal communities as well. So so where does all that fit in, the geography and the mixed nature of our population?
Thanks. Yes, it has very much influenced our approach in that we do cover a broad geography. We deliver very different services in each of those geographical areas as well. And we do have a very mixed community. And it's for that reason that the approach we're putting forward, which is based on what we've been doing so far, it is much more about how we embed health inequalities in our work across the organisation. So embedding it in where we've got strategic transformation programmes, but also empowering our teams and services to look at the communities that they serve and take action around designing services to meet those needs. So it's not about looking top down and saying, well, these are our top 3 inequalities, because we don't have that complete picture, but also it's probably not appropriate in many ways to the services that we've got. We've got some services which are much more universal, such as primary care and health visitors. And for those services, it probably is appropriate to start looking at what does access look like by deprivation level, by ethnicity, for example. But then we also have services which by their very nature serve populations which are at high risk of health inequalities, such as our LD services, our forensic services, which work with people with very complex needs and histories of trauma. So those services are much more about how do we support people to navigate the health inequalities that they've already experienced and are going to experience in their lives. So it's aimed to be quite an adaptive response for each service, rather than we're going to address health inequalities in one way across all our services.
I think that's helpful, Sarah, but I suppose maybe come back to it is about understanding the different demographics, because people might just focus in on one element of health inequalities to the exclusion of others, and it will vary from different ICB areas that we cover to another. And maybe there's something from an earlier report we should circulate against the board, particularly for Steph and Keith, who are new to the board, just to put this in the context of who are the people, who are our communities, and where does the access to health and outcomes fit into that? That might be helpful. Would that be helpful to some of our non-executive directors, just to be reminded about some of those demographics? Yeah, that's sum up. It's putting a face to the jargon, isn't it, really, as well? But yeah, okay. If we can do that, that would be helpful. Dean?
Yeah, thank you. Thanks, Sarah. I just wanted to a few points, really. Something about structure, something about content, and something about timeline. So in terms of structure, I think it's a good structure, Sarah, just laying it out around the trust priorities. I think that works. Just in terms of content, I know there'll be something around this big agenda where it's really important that we work with other partners. So, big drivers of health inequalities effectively being poor. So, housing, education, employment are all things that we can contribute to, I think, as a civic partner. But I just wonder, maybe we could do some things about where we have touch points with people that drive health inequalities. So I think smoking is still the biggest, aspect of health inequalities, but obesity, alcohol are all areas where we have contact with people in different ways. And I wonder whether in the content we could just touch on some of those. So the primary care part of our services, for example, sort of coming in there. So, the direct impact that we can have through our clinicians in terms of doing something that pick those health inequalities up. And then the final thing was just about the timeline, which again looks broadly fine. But I'm conscious that the 10-year NHS plan is due out just after that. And it may be that the content is known for us by there. But unless we've got a particular pressing timeline, I wonder whether it might be just worth just checking round about the time we're due to launch to see if it's worth waiting a month or two just to check it against the plan, and then we are aligned and we can pick up any sort of aspects that come out of that plan, particularly as aspects of that are looking from the the sort of treatment to prevention aspect, which I think fit in here as well. So, but thank you for that. Really helpful to sort of engage at this early stage.
Thank you. That sounds common sense. Sarah, any comment on that?
Happy to take a steer from the board on the timelines and build that delay into the timescale. I think that's a really good point around the work on obesity, alcohol, smoking. It's not something we've done a lot of analysis of so far, but I think it's really interesting the point that as well as primary care, we've had physical health support within our inpatient units, which has addressed some of those issues. Forensics have done quite a lot around weight management, for example. We've had a health trainer in our inpatient mental health units. So yes, integrating that is an excellent idea. Thank you.
I mean, if those are present, there's a real sense that you'll have a poor health outcome, and other things fit into some of the other demographics. Sorry, Stuart, I missed you there. I should have come to you before, Dean. Apologies, Stuart.
No, it's fine. Thank you. It's fine. Echoing Dean's comments, I like the fact you're going to weave the inequality strategy into the broader trust strategy. It's just a word of caution in relation to the fostering integration, partnerships and alliances piece. We've found it's quite difficult. It's easy. We can engage a bit. We can be busy with others trying to address problems, but it's probably worth trying to be very specific about what we aim to achieve in addressing these inequalities. Many of the inequalities driven by wider determinants of health whose fixing takes decades. So we probably need to choose our activity wisely in order to avoid not wasting time, but not being very effective in what we do. So just a word of warning about the types of kind of targets and initiatives we'll choose in that domain.
Yeah, and I think linked to that from a discussion at our last strategic board is some thoughts to the outcomes as well as best you can too. It's the inputs, but also the outcomes are really important in all this. Thanks, Stuart. Phil.
Yeah, Sarah, just welcome the focus. It's brilliant. It's so important. I'm going to argue against too many actual outcomes, because I really didn't get things like the core 20+5, because this is something that's deeply embedded in everything that people have experienced. So I would like to see a real focus on education of our staff about the impact on people's upbringings and their environment, on how they react to our services, because I actually feel that will make a huge difference, and that's the thing that we can change. And some of the medical outcomes we won't change. And sort of building on the person-centered approach, this really helps. And it's probably one thing that I still spend quite a lot of time with people from very deprived backgrounds that would help. It is to make sure that we've got adequate advocacy so that people can understand why things are being asked of them and to help them get the best out of our services. I think that would really help.
Thank you, Matt. Thanks very much for that. Phil, Kwame?
Yeah, no, you're right. I think that a lot of it would be collaboration, working with partners to support what they are doing already in order to. But the main focus in the trust is trying to support our staff to make sure that they look at health inequality, social determinants in everything that they do. And already we produce a equality impact assessment, which has included things like poverty, digital poverty, coastal region, veterans into our equality impact assessment. So every service we develop, every initiative we come to, we think through these issues. So that will be one of the main focus, rather than to say by next year we have achieved less percentage of homelessness in Hull, which will be very difficult because we are working in collaboration with everybody. So that,
great.
Thank you.
Thanks, Kwame. Sarah.
Thanks, Kwame, for those comments. I just wanted to link back to Philip's comments about educating staff on people's backgrounds and environment, how they present. This is quite integrated with some other pieces of work that we're doing. You mentioned person-centred care, person-centred planning. So we're doing some work around assessment and formulation about looking at that much wider assessment of risk, taking into account people's social circumstances. And it also ties in really closely with our aspirations to become a trauma-informed organisation, in recognising when people are presenting with histories of trauma and gearing our services accordingly. So they're really tightly aligned, those different agendas.
Yeah.
And let's not forget, our staff will share some of those social determinants that also have an impact on themselves. And obviously that's why we do a lot of work around health and wellbeing for our staff too. And actually sometimes you don't even recognise that when you're one of those people. In terms of that situation, because it's your normal in a way, where you come from and what you think about these things. Okay, that's really helpful. I hope you found that helpful, Sarah, having some of those inputs. Obviously, just to recap some of them for the minutes as well, maybe to share with the board, particularly the non-executive directors, some of the scoping around the demographics in our area, and what will help us to think about that. That's sort of national ones, but there may be local demographics that are key to our areas. That some of that could be shared. Dean's point about where smoking, obesity, alcohol fits into this as the determinants if you're, for poor health. Think about the timeline. I think this is something for the EMT to maybe take away and discuss, which is whether or not with the 10-year plan coming out, we should think about, what's the best timeline for the launch of this. So it doesn't feel. Not that it would be out of date, but do you know what I mean? It's like, we're ahead of the curve rather than just behind the curve, whatever the right phrase is on that. Looking at some specifics around work with our partners, what we can do, because they're so important to our success in this area. Education around staff so that they feel confident about this, I think, is in terms of their work. And I know a lot of work's going on that front already. So I think those were some of the points. So we've already had our focus group practically with the NEDs here and the board here on this area, and we look forward to the next iteration of the work. So is the board happy to approve this paper as we've discussed and been outlined by Sarah today? Thank you. Absolutely. Thank you for those questions. Sarah, thank you very much for your work on this area. Thank you.
Thanks, Sarah.
Thanks, Sarah. We'll move on now to the Humber North Yorkshire Health and Care Partnership. Have we got Alison with us today?
Yes, Alison's here.
There she is. Hi, Alison. Nice to see you. Michelle, did you want to say anything before we move to Alison?
No, just to welcome Alison. Obviously, the paper is the contents of the content. I'm sure people have read it, but Alison, I'm sure, will pick out some of the major issues that's happening. There's quite a lot happening at the moment. We'll pick some of it up later. But this is the headlines, and just well done to Alison and the team for a really successful conference. We had a few hundred people down into our international conference, 6th year this year, for our mental health collaborative conference. It was about dementia services. So well done for the team on that. But Alison, over to you.
That would have been just before we go to that would have been recorded, wouldn't it? The conference. Can we get the link sent round to all of the board? That'd be great. Thank you, Alison.
Thank you. Morning, Caroline. Morning, everybody.
Morning.
Thanks, Michelle. So, like other colleagues, I'll take the paper as read. This is our summary briefing report, just to keep members of the board updated with the work that's happening within the Mental Health, Learning Disability and Autism Collaborative. So if we just start with the conference, as Michelle said, our 6th annual conference, the main theme was around dementia, and we were launching the 5-year dementia plan. That's a plan for right across the system, with a number of sort of priority areas. So we will circulate the video. The other thing that we did was launch our annual report as well. So we'll make sure those links are circulated. And we heard from Dr. Jeremy Isaacs, who's the National Clinical Director, was our keynote speaker. And I think, really, really good speaker. And then we had the national speakers, Claire Murdoch and Tom Carhill. So really good conference, and I'd like to thank the team really for putting all of that together. Just in other things then, as we picked up earlier, the service development funding, after significant delays and hard work by everyone, we're finally able to release that funding, which means that we will be able to, as you picked up earlier, develop and implement the maternal mental health services model. And there is also some further investment for Humber into the older people's services. So that's really positive and good news. There is a slight delay in that being released, so that, as you'll see, has had a slight impact on some of the performance figures, particularly around children and young people. So we will hope that that investment now, as it goes through, we'll start to see improvements in those areas. The future collaborative model is continuing. We had the project team, which is representative of all of the providers, had a session with Hill Dickinson to kind of work through some of the detail around contracts and who holds the contracts and various legal aspects of that. And there is a follow-up workshop with that. And as I say, work is continuing. I know that Humber are undertaking a full due diligence and business case of all of the finances. So that's kind of working train at the moment. Supporting the future collaborative will be our new strategy, 5-year strategy and core offer. So that's kind of in draft at the moment and being discussed with all of our partners and providers. It's still fairly early stages for that, but I think that will bring together everything that we're wanting to do and secure that investment as we go forward. So one of the benefits of having the collaborative arrangements in the future. The performance figures are there, slight improvements where we're meeting targets. As I say, I've mentioned where we're off plan with the children and young people. Just to note on the perinatal target that Humber is achieving its target in there and doing some fantastic work. And also I wanted to note the improvement in the SMI annual health checks and the slight improvement in dementia diagnosis rates. So more to do, but that's a whistle-stop tour on the performance. Thank you.
Thank you, Alison. Appreciate that. Any questions to Alison? Phil?
Alison, it was just more a reflection. I was at a meeting locally in West Yorkshire, and they had the ICB performance data. It seemed to me that the mental health ones don't fully reflect what we worry about in our trust, and we're a key provider. And there seemed to be a different, almost on a parallel universe of things that are important, but not the key things that we worry about. And do we know whether the ICB reviews their performance data, or is this sort of nationally mandated?
Yeah, there is a robust process in place to review all of the performance data against the NHS long-term plan performance targets. So the ICB have various committees and it's presented to their board on a regular basis. And obviously we expect to have recovery plans against where actions are off track. So it'd be interesting to know what they were kind of focusing on, Bill, to give you a sort of proper answer to that.
Yes.
I think Michelle can add something. We've had some conversations about this, Michelle, haven't we? And it's Michelle, over to you.
Yeah, good question. For I mean, there is later on in the report, in the board papers, there is the long-term plan trajectory and metrics, which are based around mental health investment standard and some of the SDF monies that we get based on some of the outcomes that the government set in relationship to those monies. The trajectories have been altered because obviously the money's been not particularly forthcoming. ICBs have got the priority though to still have to use a long-term plan metrics. They can set their own, and I know that Carl and others at West Yorkshire did set some quite strange targets that they were setting as well. So, but they're not part of the mandated long-term plan targets. So we report on what is mandated, and within the collaborative we have a few that we look at that we're quite sensitive to the areas that we take special interest in, but we're more concerned about meeting some of the trajectories because they're the important ones. Is that helpful?
But yeah, I suppose where I was coming from was things like the sort of neurodiversity waiting times. Unless they're in these performance metrics, we're less likely to get support for improvement.
We won't get there's no more money about, so it's so
what I would say though, from just come in as well, is we are gathering all of that data, particularly in relation to neurodiversity. I'm hopeful that we'll have sort of some form of dashboard that shows where all the providers are, so we can bring that together collectively. So happy to bring an update on that when I do my next briefing.
Yeah, that would be helpful in terms of context actually as well, wouldn't it? Yeah, nods to that effect.
I think you've got to also be, sorry to come in, but there's a complexity within our ICB is that not all our providers are in our footprint. So, for example, it's really difficult to get data from TZESC and Mid Valley, not because it's difficult to get data from them, but they're supplying their metrics up to the Cumbria ICB. Ardash, for example, Rotherham and South Humber will put their data within the South Yorkshire Conurbation. So we have to get some information from them. So it becomes really difficult when we're looking at benchmarking. But yes, we are collecting a lot more on our ICB dashboard than we ever have. But it's a bit of a health warning on it.
Do they not? Is there not a sort of Yorkshire and Humber, for example, collection of this data across the? Maybe that's the thing.
Yeah, we can send the regional data out. We do get regional data, so we can send that out. So, Alison, if you could send the regional data out to the board, it will show you. But obviously, if you go into Humber and the HMY, it's like it isn't including all the partners. It's as much as we can sensitise it. But yeah, we can send out the regional data. There's loads of it.
Yeah, that would be helpful. Yes, good. Thank you. Thanks, Alison. Appreciate it. Have a good day and the rest of the week.
Thanks, everyone. Bye-bye.
Thanks, Alison.
Thank you. It's 11 o'clock. What I'm going to do now is I think we should take a 5-minute break and then come back for item number 13. Apologies to some of those who might be waiting to deliver. Is Pete with us for the Being Humble event, or is that just you, Karen? Not just you, obviously.
It's just me, thanks, Caroline.
Okay, all right, okay, fine. I don't have to worry about Pete waiting somewhere. Okay, thank you. Let's have 5 minutes. Let's get back at, let's say, 8 minutes past 11, and we'll go back on and we'll shut down the streaming now. Okay, after that short break, welcome back to the November board meeting of Humber Teaching NHS Foundation Trust, and we are on item number 13, and I'll ask Michelle to introduce a national update. Thank you, Michelle.
Yeah, thank you, Chair. This is a very brief update. We'll pick a bit of this up later about, obviously, there's been lots of discussion and dialogue within the press and media around the developing government plans in relation to the NHS, which I think is very welcomed really after the DARSE review, which we discussed at the last board meeting. So there's been lots, as I say, lots of conversations which we are influencing and supporting. And I did mention in the Chief Exec's report the 5 questions around the NHS change consultation, which we are responding to as an NHS organisation, which does link into the agenda. So we will circulate those. So please do let's have your comments on that. So basically, if you remember, there are 3 aims that have been said all the way through from the Labour manifesto, which is that treatment to prevention, hospital to community, and analogue to digital. So what the NHSE and the government are doing are working those through in relationship to an operational plan, which is expected fairly imminently. Now, Dean alluded to earlier on about the 10-year plan. There's also a 10-year plan for the NHS developing, which again we are feeding into. But obviously year on year we need operating guidance and operating plans. So we are due that in December. If you remember last year we got it in May, but it is due out, and I think they are working quite closely on developing that at the moment. What is really clear is from the conversations is that after the recent autumn budget, the NHS did really well from a financial point of view. If you remember the financial uplifts, the capital allocations, which has been stressed, must only be used for capital. So cannot be converted into revenue expenditure. So that's quite an interesting take on that. But it's really quite clear that the money now is the money within the system. And there will be no further monies because of the position from the Treasury. What is also seeming to be clear is the constitutional targets will remain. They're not going to look at that, and they're not going to relook at the 22 Act. So everything that we do will have to be set within the NHS Constitution and within the 22 Act. One of the main talking points is 18 weeks. Now, one of the things I'm trying to stress on NHSE, ICB and the government is the 18 weeks has to include, if they are thinking that is one of the key measurables, has to include mental health neurodiversity, which I think is a little bit more of an ask, but I think we need to make sure we've got that parity in the conversations. One of the things that I have actually identified is that the NHSE will continue to develop the performance management aspect of the service. If you remember, there's been quite a bit of anomaly as ICBs have developed about which roles are which, but it's been really clear that going forward, the operating guidance will say that the performance monitoring and management will come from the NHS executive. Whereas the ICB will be key in that strategic commissioning role, but also developing neighbourhoods. Now, we're not clear what those neighbourhoods are going to look like. I think there's not going to be a lot of prescription, so we're working through that at the moment with our ICB, and it's highly likely that the 3 collaboratives will come together, the primary care, community and voluntary sector, to start to build up that neighbourhood piece. So ICB, strategic commissioner, neighbourhood developer, NHSE, the regulator. And as we know, there's going to be changes at the regulator from a CQC point of view. 5 key areas then that Amanda Pritchard, the NHS Chief Exec, has built up, given that context. Obviously, we're waiting for more context behind that, with people like Tom Reardon as well, who's the parliamentary secretary, second secretary or whatever. The first key area is living within the money. So each penny that we have has to be well spent and with tightened accountability, but also to reduce that duplication. So I've put in the paper a little bit in blue where I feel the organisation is in relationship to that particular element. So we have got a productivity group, we are doing some transformation work, and we will be brought more into those conversations as they happen. The second is about embedding improvement and adapting that continual, constant improvement approach linked with NHS impact. Well, we've had lots of conversations here and seen lots of papers about NHS impact. So that will continue to develop. And I think that links really into productivity. The third area is that quality and safety. And it mentions in here about, it's an intelligent board. That's the spelling mistake, by the way. It should be the insightful board.
We are intelligent. We are intelligent. That's a given.
It is the same thing. And we're doing a draft assessment program. We were involved in developing that about 7 or 8 months ago as an organisation. So that, and it is I think it's a really quite a useful tool. So we're doing a little bit of a comparative data in relationship to where we sit in. It's another bit like well-led inspection framework. Working better with primary care. And then the joint focus on developing neighbourhoods, which I've alluded to. And then the other key thing Amanda mentioned was about making the most of what we've got. So if we've got any SDF monies, if we've got any digital monies, any capital monies, we've got to maximise the use of that, because the money is the money, and linking it into the cooperative piece. The third part, it mentions the evolution of the operating model. I won't go through that, you've read it, but basically self-managing systems, self-improving organisations, simpler, avoiding the duplication, shifting that resource from the acute sector into the communities, and devolved commissioning, or more strategic devolved commissioning, but more devolved accountability and decision making. So it's a very outline of the conversations that are taking place. Obviously, we're influencing and supporting those, and again, I'll pick those up a bit later, but it's just there really just to set the scene. We will pick this up a lot more at the strategic board as it develops and as it goes on, but just there for information. It just said to ratify actually on the agenda, but it's actually just to note, if that's okay. I'll leave it there, Chair. Thank you.
Thanks, Michelle. Any questions or comments from board? Dean? You're on mute, Dean.
Apologies, just a very brief comment. Thanks for the update, Michelle. And on that 10-year plan sort of engagement, Lynn and I both went to an event in York where we sort of contributed to some of that sort of engagement, and no doubt there'll be more on that later as well. But thanks for the update.
Yeah, thanks, and thanks for attending that, Dean. Yeah, there will be. Yeah.
Thank you, Dean. Stuart.
Yeah, Michelle, it's very helpful to get that kind of big picture summary of all the different concepts being worked on. On our own productivity work, are we looking at the productivity of organisational form? And I say that in context of the previous paper on the collaborative, the bigger collaborative. We'll be doing this work, won't we, on developing our organisational proposal going forward. But it's easy to get lost in productivity about kind of frontline or patient-specific caseloads without really understanding the productivity of the kind of the infrastructure that goes above it. So are we looking at that?
Yeah, I mean, I don't personally like the word productivity, to be honest. I think it's about how effective and efficient we are, to be fair. But yes, we are looking at that. So that's our infrastructure costs. And if you remember, we talked about the reference cost system before. So we do constantly review, and I'll bring Pete in a second because he does chair that group. But we do constantly look at our management overheads and our cost in relationship to that. And obviously, one of the things we're looking at wider in the system is how organisations can work closer together to continue to reduce that. So yes, we do, probably not as much as we should do, Stuart, to be honest, but we do.
Yeah, and I suppose I'm still struck very heavily by the fact that the NHS has a certain way of working that has lots of layers. You don't see that in other industries or even other public sectors, and I don't remember us really spending time as a board understanding the relationship between the amount of resource that goes into what you might call kind of strategy, regulation, control, overhead, as opposed to front line. So it's a method that was quite alive in the local authority sector about 20 years ago. I just think it might be worth just having a bit of time on that in due course.
Michelle, are you on mute?
I'll say it again. I think that'll be quite a useful conversation, because it'd be quite useful to link into the conversations that we're having as well.
Exactly.
I think you're right. And one of the things I think Amanda was alluding to is that tiering and that duplication, because at the moment we're just reporting into loads of different people with slightly different metrics, or sometimes in the same metrics. And you just counting the same things, and it is distracting, but it's also very, very, very costly. And I think it's quite interesting about the 22 Act, because it did bring another layer into it, which obviously now we're having to cost out as well. So, but Pete, do you want to pick up anything about the productivity group and work that you're doing?
I guess linked to productivity and corporate overhead, Michelle, is we continually review it, don't we? Annually as part of workforce planning. We participate in NHS benchmarking and corporate costs probably biannually, and we tend to, identify areas for focus there. We tend to benchmark quite well, actually, and something we'll probably take through Finance Committee, Keith and Stuart, but it is continually reviewed annually as part of the workforce planning round, Michelle, I think is, my view. And we have an annual BRS for corporate services, as we do for clinical.
Yeah, I'm not saying we're not doing it. But I wonder if we could be, you could think the radical, couldn't you? Say, let's design something that's so small so the function that isn't frontline is so small. What could the smallest design be like in the context of our future work?
No, it's a good point, Stuart. It's a good point.
I think it's an interesting question around, some of the things that we do, which ultimately, what control have we over that sort of numbers of different layers that exist? And it came up, I think it was last Friday, I went to a webinar organised by NHS England on the operating plan, but also at NHS Providers Conference. And I'm sure it came up at the one that, in the one form or another, that Dean and Lynn went to, was just sort of clarifying what are the roles of different organisations. And that's why the issue around NHS England being the performance and not duplicating that at the ICB level, I think is really important to thrash out. And the danger is you end up with mission creep. Everybody says that you have these different roles, but you end up with this sort of mission creep where slowly they get involved in that as well. And likewise, a lot of discussion around duplication of reporting, or not aligning different themes together under one performance framework, or not creating lots of staff working in different units. So, I mean, we all know that, at the centre and region, you can end up with a proliferation of different roles, when actually there's a lot of connectivity and synergy between those roles that could be better worked together without creating lots of different streams of data collection and reporting lines into them. So I think it all has a cost. It all has a cost to bear on then what's available on the front line. So I think it's a point well made there, Stuart. And again, for us to escalate as well upwards. Can I just ask a quick question before I bring in Keith? What is happening about our regional director? Because Richard Barker hasn't been replaced yet, and it came up amongst some chairs from Yorkshire and Humber the other day about feeling that we're missing out at not having that role resolved and someone properly recruited to it.
Well, obviously, Rock and I were within that post. My last conversations that I had with the team, what they were starting to go out in the recruitment in the new year. So because obviously
it's been a while, hasn't it?
Yeah.
Because the North East have got theirs, but we haven't got ours in Yorkshire and Humber sorted out. Okay. Keith.
Thanks, Caroline. I think it's to add on the back of what Stuart just said, actually, in terms of that. I think, Pete, the external benchmarking and stuff like that, and benchmarking ourselves against those is really useful. I suppose my add-in is that intent to say we've always delivered in the way we deliver, and the NHS has a tendency to benchmark itself against that continued delivery, and it's that ability to step back and say, do we need to deliver it in the same way, and could we therefore look and feel different? And that isn't easily adopted in the NHS. I think it's not a criticism, it's more a reality, I think. So it's that ability to be slightly more step back with ourselves and be a bit braver and say, actually, we could deliver this differently. We could be smaller, we could be differently shaped, and therefore where do the economies of scale come from doing that? So I'm not saying we're not doing that. It's more we need to really make sure we challenge ourselves to look at the current picture, but also what could the picture look like?
Thank you, Keith, for that. Thank you. Michelle, anything you'd like to comment on before? There's no other hands up. We move on to the next item.
No, I think that's been really helpful, and I think picking up Stuart's point and others, I think as obviously as this agenda continues to develop over the next few months, the more conversations we can have, the better on it. But as I say, people have got comments like that they want me to feed into the ongoing conversation while we can influence it. And just drop me a couple of headlines. That'll be really helpful.
Great, thank you, Michelle, for that. We'll move on then to item 14, Karen.
Thank you, Caroline. So, yes, you've got me today. And I think just largely, just to pick up some highlights of the paper, the presentation and the paper you have isn't hugely dissimilar to the one that Pete Cook presented back in September when he updated the board that we were refreshing the behavioural standards. We were going through a process of extensively consulting across a number of key stakeholders. We're pleased to say that that process is now finished, and I present to the board today the final core document that has been designed by our new internal designer, actually, which is great to see. And what this sees is much strengthened behavioural standards. And obviously, we know that Being Humble was launched in 2022. But given some of the conversations we've already had today, you'll see that those enhancements include some of that focus on health inequality, learning from incidents. So relating very much to common themes and work that is a core focus in the organisation at the minute, particularly around safety, preventing closed cultures, etc., etc. So I am asking the board if you'd be happy to approve the core document. There will, of course, be a formal launch and other supporting resources that will align to this document design as well. So I'll leave it there and take any questions.
Thanks, Karen. I thought it was a really good document and quite a talking point when you read through it, I would imagine, within teams as well, creating that too. Any other questions, comments from board? I'll be happy to. Oh, sorry, Stuart.
Yeah, so I said this last time, but maybe I want to say it again just for because I think it's important. Given the previous conversation we've had and the emphasis on making good use of resources and the shift from analog to digital, none of the words. I love the words, by the way, in this document, but they're not. There's not much hard edge about resource use, being digitally savvy, having an eye to the most efficient use of using our assets or our being productive. And I know sometimes there can be kind of like not very friendly words for people, but it seems to me the tone of our current environment is about all of those things. And I know this is a near final document, and I like the design, but I'm slightly concerned we might be missing one of the points.
So just to say, Michael Heseltine once had a thing in government where he wanted up on every screen, computer screen, that whenever a civil servant opened it up, it would say, is this helpful? Or words to that effect. Why am I doing this? Do I need to do this? It was that, I'm not saying we should follow that route, but you get my drift. It was about that sort of sense of, you know, do I need to really send 1,000 emails? Karen.
You make a very interesting point, Stuart, and I don't necessarily disagree with what you're saying about the strength of this. I suppose this should be intrinsically linked across everything that we do. And I do think that, and I'd be happy to take further comments on this. We can go much further with this and we can make it a much more enhanced document. And we can certainly look to intertwine some of that, because I think you're right, there are some key themes here. But actually, what we do hang off the Being Humble framework is all of the other cultural work that we do. So what I might recommend is that actually any work around productivity, efficiency, the move from analog to digital, that we can pick up that link through those particular documents and make reference to the behavioural standards.
I think it's slightly different to that, if I'm hearing Stuart correctly on this. What it is about a state of mind, about when you come to work, could I do this more efficiently? Am I using resource? I'm not saying use these words. Am I using the resources well? Am I getting value for money? Is this working? And people that are creating that sort of sense of, I suppose, just, not just getting into a groove about how they do things every day, or thinking about how they might transform. Now, that's a bit different from the sort of how we treat each other, how we, you know, treat patients. It's about a state of mind about what is my purpose as I come to work, and how do I work, and how do I think about these things, and take things like productivity and make meaning of it in our daily working lives. I think, is that fair, Stuart?
That's exactly what I'm thinking. So,
that well?
and I'm also, again, I'm not saying people don't think in this way, but if you read the words that we've got on these pages here, they I don't think anywhere refer to, when I come into work, I might think, is there a different way I could do this which would maintain patient safety or even improve it, but actually mean that I could deal with that long queue of, it's on my list of people yet to see, or I could work with partners where together we could collectively, you know, get more for the public pound that we're investing. And again, the words I'm using are the ones that I'm familiar with in my kind of area of work, which can be regarded as a bit negative for those who are primarily concerned about people. It's a bit unfair, people rather than resources. But I'm worrying we are not getting the balance right. And I'm just rereading the words in the previous paper, the national briefing paper, about the kind of things that we're being asked at policy level to have regard to, and I'm not seeing the match.
I don't know if Michelle wants to.
This is probably really annoying, right? Because you're very far down in development.
Yeah. I think it's a really good point, Stuart. It's a really complex point, and I think it's really interesting how we interweave what you're talking about, because you can have that conversation about any organisation, not just within the NHS, about, because if people work in a factory, if they work in Marks and Spencer's, if they work in a local authority, they are going to do things exactly the same way, that non-appreciative, not appreciative, but in what's the word? Looking at how they do things, because they get set in their ways. Because you can argue we all do to some extent, whether we're at home, we get set in our ways, what time we have dinner, what, you know, all that type of things. It's how do you break that? And I think that's the next reiteration of probably what we're doing about our cultural journey. You've got to think about where we've come from on that cultural journey. We want to develop a community, we want to develop a way that people behave towards each other, that professional curiosity, that professional challenge. And in a way that then brings about that way of actually, why am I doing it like this? And, you know, I'm being humble, but actually I'm going to have that professional curiosity to say, can I do this in a different way? But I think we need to work, and one of the things I'm having a conversation about the national team is we need to have a word with our clinical leaders as well around doing things in different ways, because sometimes they get very prescriptive. We've got there are very prescriptive ways of doing things. We've got policies, procedures, nice guidance, regulation, guidance that actually does tie you up in a bit of a knot, because people may say, well, actually I'd rather do it this way, but I've got this regulation to think about, I've got this form to demonstrate that I've filled in, etc., etc. So we have had a bit of a mantra that does, and I do hear it around a bit, which is seek forgiveness, not permission. And I think it's about how we start to interweave that within the Being Humber framework, and that should then tie it in. But I don't think they're separate, to be fair, but it's really complex. How do we, as a board?
They're definitely not separate. They need to be part of the to be developed mindset, if you like.
Yeah. So I think we've got to do it in stages to develop that mindset about, you know, this is where we've come from. This is our first cultural journey. This is our next cultural journey in relationship to Being Humber behaviour that leads to that professional curiosity, that appreciative challenge. And then we can then be really clear around, well, let's completely reinvent the model and start to say, really, let's really reinforce about outcomes and making sure why we're doing things, etc. And I think that will start to develop over the next year, and especially when we get into more being allowed to do that, because I think there is this a bit of anomaly that, well, we're not allowed to do that. We can't do that because we're not allowed to do it. You know what I mean? And I think it's how do we break that cycle? And that's really difficult. And the only way you can start to do that is to have a real good culture where it's supporting. Does that sort of make sense a bit? I think we're on the same page, but it's really difficult to link together.
Well, I think, a good example about on the first page about, if you like, putting patients first. You know, if people are on a waiting list for a long time, is having a perspective which is, what can I do to reduce the waiting lists? you know, what can I do to support people better whilst they're on those waiting lists or whatever it might be. I'm going to bring in Dean, because I'll come back to you, Karen, because you might want to wrap up listening to people's comments here or answer those comments. Dean.
Yeah, thank you. Just really interesting to listen into the discussion, isn't it? We get that sort of sense of, I guess, a sort of changing context as we go into that sort of 10-year plan preparation and money being tight and all the other sorts of things that we're going and sort of finding our feet as we go. And I was just wondering, as I sort of look down the timeline, Stuart, you know, given the work that's gone on in terms of consultation, in terms of producing the document to date, whether there are some opportunities to pick up some of Stuart's points in for example, we've talked about, you know, collecting examples of good practice, where we do the implementation of the communication strategy and sending feedback out to people, is whether there's some ways we can capture some of the things that Stuart's talking about as part of the way that people may use this to provide that better care, as a sort of build process that you were talking on, Michelle. So I just wondered whether there was stuff in the rollout that allowed that development to come through, recognising it is that sort of changing landscape that we've got and everyone's iterating at the moment.
That sounds like a good idea, because then you can provide people with some sense of scenarios in which they could apply the values to how they actually deliver the work, and also engage in transformation as well as part of what we want from them to do. And what you said, Michelle, about professional curiosity, you know, and it links to the freedom to speak up, doesn't it? If you've got a good idea or you see something not working, you know, speak up. If you've got thoughts and things, speak up. We want to hear from them. It's that sort of thing too. And there might be scope for that, as you said, to incorporate that in the rollout and discussions and implementation, if you like, as well as come back in the way that Michelle suggested. Karen.
Yeah, I was just going to come in really and compliment what Michelle had said, and I suppose this is about the place that the organisation is in terms of its cultural intent, and what we want to do is create that safe, engaged organisation where people will, whether it's report incidents or treat one another with respect. And I completely agree with what you're saying in terms of the direction of travel. And just what I was going to say before Dean obviously came in first was what we can do, because I think actually sometimes core documents can be quite subtle around what we're trying to achieve in order to get our message across and get people, win hearts and minds, I guess. We can be much more explicit around some of the points that you raise, Stuart, particularly in our supporting documents, whether it's those specific scenarios or, and Caroline articulated it quite nicely around some of those, you know, how can we reduce waiting lists, etc. How, you know, what's my part to play in that? So we can definitely deliver more explicit messages, I think, as part of that supporting resource, case studies and things like that. And at this stage, maybe keep that core document as that subtle tool to win those hearts and minds, get people engaged with the behavioural standards and to be able to embed it that way.
Stuart, would you, oh, sorry, Lynn, I'll take Lynn and then just come back to Stuart since you've initiated a really interesting conversation. Thank you, Stuart. Lynn.
Yeah, I just wanted to add to Stuart's points, which I think are really relevant, as you say, given the national context at the moment. But I do think we are reflecting those, Stuart. When I think about the patient care performance and accountability reviews and how those have developed over recent years, with that focus on accountability around productivity, efficiency, transformation, doing things differently, and how that sort of links to focus on outcomes, not just tasks, and sort of what that means. I think we can see those behaviours, not just at senior divisional level, but now sort of being translated and embedded. There is more work to do, but I do think that links exactly to what you're saying. So I do think we've got that sort of grounded approach taking place, but I do think it does need to be connected to this behavioural standards cultural piece as well, more explicitly than we're describing. I think it's a really good conversation we're having about this. Thanks, Caroline.
Thank you, Lynn. Stuart.
I have to be careful what I wish for, don't I, sometimes? And so what I've heard is then there's quite a lot going on inside the trust about the things I've been talking about. My point remains, when you read the words on this Being Humber document, and we set a lot of store by Being Humber, don't we? The words don't reflect what I've just been hearing. So given the development stage we're at with this document, maybe there's a chance in a next iteration to weave in some of those connections in a subtle and engaging way.
Yeah, I think that's the next iteration, Stuart. It's the one that we're constantly evolving. It's not a fixed in term, it's that development piece, but I think that's what we're trying to articulate, that we will build that in as we go forward.
Okay, thank you. Also, we don't have to wait for the next iteration of the Be in Humber to think maybe more about how we use that, some of the conversations that comments people have made today, and weave that in, because I think again it links to other stuff that we've had recent discussions around the strategy, about that sort of how can we better capture the outcomes which are happening, and where they're not happening in the way we want, identify that they're not happening, and the gaps as well. And I think that's an ongoing piece of work which would help, I think, pick up a number of your points, Stuart. So we have, if you like, I suppose, a platform for that we're really confident about in expressing, that then can work its way into a lot of different documents where it has a role to play, and this is one of them as well, I think. I hope that reflects the conversation, but we can take up, as Dean suggested, somehow this is rolled out and some other elements that can be included in it going forward. So with those provisos, is the board happy to approve this document, or content to approve this document? Great, thank you very much. Okay, next item, it is there for you to remind you around our December meeting, which we are having another session with Susan Young, around our working together as a team, as a board, followed by the board Christmas lunch. I hope everyone will be attending. Any non-attendees? Speak now. Oh, Pete.
I'm on leave, Caroline, but Ian will be attending on my behalf.
Okay, that's fine. We must make sure that he's put on the list for. We're having a bring a pick and mix, bring stuff for the Christmas lunch. So we better make sure Ian is on the list to provide something. Great. Thank you. We'll move on then to the finance report. Pete.
Thanks, Caroline. So I'll take the report as read, but just pull up a few points and then move to questions. So within the report, we highlight the system financial position, where you can see at month 6, the ICS had recorded a year-to-date adverse variance of 1.4 million. But I guess more worryingly, that for the ICS to get to financial balance by the end of the year, there's £27 million of efficiencies that need to be delivered that are currently not identified in plans. And that seems to be a figure that's increasing month on month. And I'm sure in part 2, me and Michelle will give a bit of an update on the headlines from the current month 7 position. You can see at the back of the report, the ICB produced a checklist for trusts to work through following the recent summit. But on top of that, other actions are starting to get proposed that trusts have been asked to consider. And again, I think it's probably worthwhile picking that in topical later today. For the trust, at month 7, you can see we had a minor variance to plan at month 7, and that was purely the NHS Agenda for Change pay award pressure we've got, where the level of funding we've received of the trust doesn't actually cover the full extent of our Agenda for Change pay uplift. And that's primarily because the weightings used in the pay award calculation are probably more geared towards an acute organisation, and we have a high proportion of staff costs to non-pay. We are still continuing to forecast to hit our plan for the year, but there are 3 risks that we've pulled out and identified in the paper to delivery. Those are the local government pay award, and that's about £300,000. And the advice we're getting from NHS England is there's some guidance due to come out, and we should assume that that funding will flow. We've got some income that we assumed in our plan to get to break even for the year that we're expecting to flow from the ICB, and that's 933,000. And again, the ICB are saying we should expect that funding to flow as planned. And then finally, we've got the Agenda for Change pay award gap. I guess as an organisation, if we can manage, we do receive the income we've been told to expect to achieve, we would expect to manage the pay award gap in year, given the size of our organisation and the materiality of that. And I think that's right. And then just linked to that, and it's not in the paper, Caroline, but it's basically running at pace. We've had a notification that there may be some additional capital available to NHS trusts. It was an incredibly tight turnaround, but part of that is asking if there's any revenue to capital schemes we could put forward to manage our position. So we'll obviously put forward some priorities based on our 3-year capital programme that we could probably bring forward. But we're also mindful to say if we could get 500,600,000 of capital funding, we would use that to improve our revenue position and somehow look at a rev to cap transfer. So I'll stop there, bit of a whistle stop tour as usual, but I'm happy to take any questions on the paper.
Thanks, Pete. Any questions or comments on the paper? No, very clear there. Oh, sorry, Phil.
Yeah, it's just it's a small amount of money, but it's about Humber Primary Care and the forecast overspend of 0.414 million. Just clarification: is that overspend on budget or total overspend? And do we know what percentage of turnover that is? Because it seems, for quite a small turnover, it seems quite a large deficit. And is it due turnaround or?
So, as I understand it, Philip, that's variance to budget. So, and in terms of turnover, that's probably about 10%. You know, I'll get a formal answer, but that's roughly 10% of turnover.
And do we know what percentage versus? So it's of total overspend it is rather than against budget? Because I think it was budgeted to overspend, wasn't it?
It's a subsidy. Yes, there's a budget for primary care of about, you know, when you include pharmacy, it was about 850,000 this year. So, you know, very quick maths for me is about 50%.
Yeah. Okay, it'd be useful to know what sort of level related to turnover, because I'm just trying to get my head around Humber Primary Care particularly.
Yeah, I'll do a post-meeting note if that's okay, Chair.
That's absolutely fine.
That's fine. That's great.
Yeah.
Thank you, Pete. Thanks for that question, Phil. I can't see any other hands up. Thank you, Pete. We'll move on to performance report, please.
Lovely. So I'll do the introduction, Caroline. I'm sure some of my exec colleagues might want to add in before we move to questions. So this is the performance report at month 7. Generally presents a similar pattern of performance that we've seen in previous performance reports at the board. I guess some of the key points I would pull out is obviously sickness continues to be an area of concern, but we are in the process of doing a series of deep dives across our inpatient units, and I'm sure Karen will cover that. You'll notice within the paper that the waiting times for forensics has been excluded from this report, and that's purely to do with the data migration for the EPR, and that'll be rectified for future reports. So we probably expected that, and we could have probably warmed the board up to that in the last report. You can see the long-term plan dashboard does show some performance challenges, but I would link that to the conversation we was having earlier in terms of service development funding and the lack of investment in some of those priorities this year, and that did inform part of the planning round. You know, I think I'll stop there, Caroline. They're the ones I wanted to pull out, and then happy to move to questions unless any of my exec colleagues want to pull anything out.
Before I bring it over to Karen. Yeah, Karen.
Yeah, just to pick up on Pete's reference there to sickness. So you can see on the Safer Staffing dashboard that sickness remains quite a challenge across the inpatient areas particularly. So what we have done is carried out a deep dive into the sickness absence. And as a bit of a resolution to that and to move this forward, Lynn and I are actually acting as joint SROs to a bespoke piece of work, a sickness intervention, as it were, across 5 of those areas particularly. So some key colleagues from the operational teams that represent those particular areas alongside members of my team are actually developing bespoke plans to try and address sickness absence in those particular areas. That might be including, you know, educating and training managers to better deliver return to work interviews, to look at stress risk assessments, occupational health intervention, etc., etc. So that's sort of in its infancy at the moment in terms of rolling out those plans across those areas, but we've got really good engagement. So what we're hopeful to see is that whatever package of support that we do deliver in those areas is something that we can then reflect in other areas of the organisation.
Will you be looking at, for example, what types of sickness we're talking about here, and whether it's long term or short term? If it's a days every other week as opposed to someone being off for a considerably longer piece of time, will that be part of your looking
absolutely
more deeply at this?
Yeah, so that happens as kind of business as usual anyway, but we'll be really getting under the skin of that in these particular areas. So we will, for instance, be looking at, and we know that stress, anxiety, depression as a reason for absence is the highest reason for absence across the organisation. That is the same in those areas. So what intensive support can we give to support from a psychological perspective with occupational health, with health and well-being? So like I say, whatever model we look at, it will be bespoke to those particular areas, but hopefully we can replicate elements of it and relay those in other areas of the organisation.
Thank you for that extra information, Phil.
A couple of questions about some good news stories. Adult ADHD long waiting lists over 52 weeks have reduced dramatically in the last 2 months from 600 to 350. Be useful for board to hear maybe how that's happened. That seems very positive. And the CAMHS waiting list, it seems as though we've eliminated or virtually eliminated greater than 52-week waits. I was just wondering whether it's time to look at some more challenging targets, such as having 52-week waits as sort of never events and reporting at 18 weeks, something like that for CAMHS. But both positive moves, seemingly.
Thank you, Phil. Lynn, do you want to come back on that?
Yes, thank you, Phil. I'm afraid on adult ADHD, it's perhaps not as positive as it appears. That's because we've temporarily closed the waiting list in order to address the waiting times. That means that service users still can access, although they'll wait, via the right to choose route. So it's not as if there isn't an alternative route to access services. However, you're absolutely right, Phil, around the core CAMHS and the access times. So and we benchmark very well comparatively nationally. Actually, our core CAMHS waiting times are very nearly 18-week compliant, which is fabulous work that's been done by the teams around addressing that waiting time. We don't want anybody waiting, but we particularly don't want children waiting. So I think it's a fair point you make, actually, Phil, and I'll take that away in order to think about how we reflect. I think it's back to Michelle's point as well around 18 weeks nationally and sort of where that direction of travel goes. And I think I did raise it at the last strategic board session in relation to our strategic goals as well around sort of the 18-week position. So I will take that away, Phil, and have a think about that. But thank you for the positive feedback.
Thank you, Lynn. Thank you, Phil, for the question. Stuart.
I had a similar observation as Phil, actually. So thanks for explaining the adult ADHD curve going down. It's kind of a bit of a false positive, isn't it, there? But I think that it's the trends on page 149 of the pack, the pediatric ASD and ADHD waiting lists for 52 weeks. It's going up and up and up and up and up, isn't it? I feel that's our real Achilles heel across the whole of the performance report at the moment. And I'll make the link later on when we look at the BAF in relation to whether this particular page, how important is that in the context of our overall performance. But if you look at the data on that page 149, so there's like almost 1,000 children in a waiting list. No, 1,500 actually, the two graphs together, more than 1,500 children waiting for treatment. That can't be good.
Lynn, do you want to come back on that?
Yeah, I do want to come back on that. And obviously we did take a paper, I took a paper to the Quality Committee very recently, in fact, the last Quality Committee with detail around that. And obviously it's constantly discussed and reviewed by EMT. Our view is genuinely we are in dialogue very much at the moment with our commissioners, Stuart, that we can't just continue to add children to this waiting list. There's got to be a radical change of model. We've discussed that here before going forward. but we are saying that unless there's some investment in the waiting times to reduce it, as we were able to do previously last year, then we're going to have to look at that position around pausing, adding additional children to the waiting times. So we are in dialogue around that at the moment. That's not where any of us want to be, but that is the sort of, you know, assertive position we're having to put into the system because of the risk to those children and their families, but obviously the overall organisational position around that risk as well, Stuart, that we are, you know, all really aware of. So I will keep you all obviously informed. I know Michelle's got her hand up about where those very active conversations are going to go with that.
And this is for assessment, isn't it, Lynn?
It's for diagnosis
as opposed to treatment. I think, you know, that's it,
yeah,
you know,
and it's not ASD, as you know, it's not treatment.
Yeah,
Caroline, it's a neurodevelopmental disorder where support is what makes the difference. That support should be offered early. It should primarily be focused in education in schools and to families. And we've discussed here before, and interestingly, I know Dean referenced that event that we were at last week, and I raised the issue around neurodiversity and the national position, and we've got to have a radical rethink around that as well, which I know others are raising in the system too.
I think the language around, so I was just going to say, Michelle, the language around all of this is really important because people just think treatment, don't they? I'm not saying we do, but I think people in the public space think it's about treatment, and actually it's not a one size fits all at all in this space. Michelle and
yeah, I mean, it's a really good point, Stuart. But I mean, we've got to we've got to acknowledge the position. First of all, our staff work really hard, and we know that we are productive. It's one of the things that we look at from an effectiveness point of view to make sure we are utilising what we have and the resources that we have got to the maximum. So let's be really clear about that. And we continue to do that. You know, can we use more digital? Can we do, you know, different follow-ups? Do we use different types of services? Do we contract out? So we're constantly looking at the different ways that we can maximise the money that we get in. But it is really clear that we do not get enough money into the service for neurodiversity in all its widest treatment and modality pathways. We have continued to say that, and until we raise that, and we are raising it from a national perspective, and that's why I said earlier on in the presentation earlier on around the 18 weeks. The 18 weeks is just at the moment for elective in the acute sector, and I am arguing vehemently that 18 weeks needs to be for children and young people, within that the neurodiverse piece, but it will be so costly. Now bear in mind that we have to live within our money. That's why we going to have to make, I think, in the next 12 months, some difficult decisions about what we stop investing in and what we invest in. And this might be that we shift some money from A to B. Yeah. And they're the sorts of conversations I think that we need to get into. What is really clear is we have to ensure that we keep the people on the waiting list informed about their waits, that we look at the quality aspect, which is what went to the quality board. And we don't want to pause. I won't say close, I don't like the word close, but we don't want to pause our waiting list. It is a really difficult, uncomfortable position to do. But sometimes I think it is absolutely the right decision to make, because it's almost in a way trying to be in the best interest of the patient and the family, because sort of saying, well, yes, we'll take you on, but you're going to be sat on a waiting list for 2-3 years is not acceptable. So the right to choose to go somewhere else, or at least to start to ratchet up the importance of it. So it's a really good point, Stuart, and I think it's something I feel really strongly about, that we are absolutely maximising what we can do. The demand is phenomenal. We have to look at the demand. We also have to look at not how we deal with individuals within the NHS, but how do we prevent that? It's something earlier on. We know the first 1,000 days are so important, so we have to put more resource into that first 1,000 days to stop that neurodiversity pattern happening, because we know, you know, what some of the presentations equate with. And that goes back to the health and equality strategy, but it also goes back to how we actually support that first 1,000 days of somebody's life. So it's a whole complexity, myriad piece. But I think that we are trying to influence it. I think it's a good question to ask. I think obviously you get the detail on the waiting list report, but then just quickly going back to Philip's point, I also do think we need to give ourselves some stretch targets. as well.
Yeah, sorry. Sorry, I interrupted you there, but I raise it. I'm not trying to say are we doing enough about it, but I think as a board, we've got this very long-term trend now. We're engaging with essentially the commissioners and funders. I think we're saying as a board, look, the way we're operating, if we want to make sure all the other service lines are protected in this, given this particular group of patients, people under 18 waiting for diagnosis, we are not able to deliver on our mission because there's simply not enough resource in the system. We're thinking of ways about delivery. We're doing our best to keep people informed, etc. But actually, we are not going to deliver what we want to do given the context. The reason I think that's really important is when we get to the BAF discussion, we're saying in relation to all of our objectives, we're within tolerance of risk. That doesn't feel to me a sensible conclusion, given what we just say across the piece. I'll come back to it when we get to the next paper. But I think as a board, we're simply stating, aren't we, that we cannot deliver on something we want to achieve because of all of those things in play.
Yeah, I think.
Yeah, I think we're saying the same thing, Stuart.
Yeah.
We're saying the same thing.
We are. Yeah, I want us to be explicit as a collective group here.
Yeah. And the other thing about going back to, I think Michelle said, or Lynn said, forgive me, about the model, it's broken. It's literally broken, because the truth is that, as we all know, those children and their families are asking for help, and there is clearly something happening in that child's life that is not helping them at school, not helping them at home, not helping them in their relationships with their peer groups. It may be ADHD, it may be autism or another neurodiverse condition, but it may not be that. And that's the other thing about this, and why the model is so broken, because it just, drives a route. And again, at the NHS level in discussions, there's a massive issue of expectations around this, and about having those, quite sometimes difficult conversations with the carers in those children's lives about what it may be and what it may not be. And how that is managed as well whilst people are on the list, because actually it's not just about the money, it is about the context in which this area sits, as far as I can see, as well, and about what's driving the numbers down this particular route, when there may be other things that actually should be first and foremost part of the conversation with the child and their family that isn't there. It's driving a behaviour, and it's driving a way of doing things that isn't just, it's clearly not working. And you're right to raise it, Stuart. And I think Michelle and both Lynn are right. It's the broken model of this. Phil.
Yeah, I just want to reassure board that quality committee is all over this, but obviously it's a bigger issue than just the trust. And what it's revealing is that the NHS responds very badly to changing patterns of disease. And this is a dramatic change over a relative short time, but it's just not responding. And Michelle and Lynn are talking all the way up the system to try to get some recognition, and it feels very frustrating. Just a specific issue, Lynn, that I've not heard us talk about is that there is a shortage of ADHD medications. And the medication, to change medication, so if something like Ritalin is not available and it needs to be changed, it's consultant initiated only. And is this impacting significantly on the burden of the ADHD services?
Yes, it is. When we are prescribing, Phil, then it's less so of an issue. Unfortunately, what we are finding is, because of the long waiting times nationally around diagnosis for ADHD, people are going elsewhere, independent sector, the right to choose providers that will prescribe, but then will not maintain that prescribing. So we're getting a lot of contacts from individuals who've been prescribed, but then either can't continue and find a prescriber, or there is issues to accessing the medication, which obviously from a patient person point of view is a really frustrating place to be. But yes, it is having some adverse impact for the reasons that you say. We are watching that, and Kwame and the pharmacists work really closely with us on that as well.
Kwame?
Yeah, I mean, that's the last point I was going to make. We monitor that on a regular basis. I think at some point we were in a position which says don't initiate new medication because of the lack of, but now we've moved away from there. We now have different preparations coming through. So what we do is that we do get constant conversation with GPs who are asking about which preparations are available, and then we do advise them on those ones and point them in the right direction. So that's where we are, Phil.
Thank you. And of course, the worry is that people will go online or something, or will have some of these ridiculous influencers sending them down a route on some of this. Influencers who are getting paid to do this, by the way, on social media. Okay, thank you. We'll come back to this again. We'll pick up at BAF discussion, your point as well. So thank you, colleagues. Let's move on then to the committee terms of reference. It's all there. It's pretty straightforward. I think all the committees have their minor changes, and I think the chairs of the two committees that hadn't met have also seen them and are happy with and content with the changes. So can we approve the changes suggested? Item 18 under terms of reference. Thank you very much. Let's move on to board assurance and probably pick up where we left off. And we have Oliver with us. Thank you for your patience today, Oliver. Hope that was interesting, that conversation for you. Okay, over to yourself. Unless, Hilary, did you want to say anything?
I think this is Michelle's.
Michelle, sorry, Michelle, you're risk register, aren't you? Sorry about that.
Yeah, sorry, no, this is mine. But no, again, obviously, I know it is work in progress. I know you spent some time on it at the board, but I'll let Oliver just go through it, and then we'll take Stuart's point and others as they go through. So over to, thank you.
Thank you, Michelle. Thank you, Caroline. Good morning, everybody. So obviously the board assurance framework, in line with the revised frequency of reporting, has actually come earlier than was provisionally agreed. It was going to be coming as a Q2 position in February. The discussion at EMT felt it needed to come sooner than that, and obviously we'll just have a look at the work plan for next year. So the key point to stress is this is a Q2 position, takes us predominantly up to the end of September. Obviously, a lot of the conversations that I've heard today has been in relation to the current position. So a lot of that will be covered in Q3. So just to give the assurance that although this might not represent the position that you're seeing today based on performance finance information, a lot of this has already been discussed and will be covered off in the Q3 version, which will be coming to board early next year. So just as an initial point, just to highlight. I think in terms of obviously the strategic goals themselves, I think as ever, what the BAF looks to do is capture the risk to the delivery of the strategic goals. Obviously, in terms of specific risk elements, that's where the risk register would come in. So although they are related, they are distinct documents. So again, just another point to highlight, and I recognise the discussion that's taken place, and obviously we can have a bit more of a conversation around that. But I think in terms of this position, just as an introduction, and obviously I'll take the paper as read, obviously that Q2 position being presented to all of the committees of the board, and obviously any feedback in relation to the Q2 position has been incorporated into the document. Obviously we continue to take the process of review with regards to the BAF, and obviously we continue to develop it in year. And I think there's discussions around what we can do to again further strengthen it and develop on it for the Q3 position. So a lot of changes will likely be made to that iteration. In terms of the template, there will be some slight tweaks as well. But as ever, happy to take any comments, any feedback, particularly in relation to the points already made. And obviously what I would like to say is obviously in terms of assurance to particular issues, I would look to the risk register to capture that, and there'll be reference to them on the BAF. I think in terms of the overall strategic goal scoring that we're giving, there's lots of different factors taken as part of that, and also looking at assurance across the board, it won't be limited to one area of risk. So again, although it might not feel as though it captures the full kind of scoring weighted to those risks, I think Q3 will look different anyway, but obviously it's looking at a full position linked to the full strategy. So that's kind of the position we've always taken to the BAF, and we'd look to see the risk register pick up on those key issues individually. So again, happy to take any feedback, any comments at this stage, just to assist us in the development processes for Q3, any factors that we need to consider as well going forward.
Thanks, Oliver. Stuart, you haven't got your hand up. Shall I come to you though, because you obviously to pick up from where you left off on the last discussion, and in light of what Oliver said.
Yeah, and so thank you. And just to pin it down. So my observation is whether what we just discussed about the paediatric waiting lists is significant enough to either tip the innovating for quality and patient safety current risk rating up a notch, or is it conversely adequately reflected in the enhancing prevention, wellbeing and recovery page, which has got a current risk rating of 12. It's maybe just a reflection for the EMT to have a think about when do the next iteration.
Yeah. I'm seeing Michelle.
Yeah, and I think it's good. And I think we have briefly touched on this, but I think obviously when we get the BAF back to a bit of it after it's been to ODG and all its cycles, I do think, Oliver, we probably do need to notch it up. I think let's have a conversation at EMT, because especially now we've paused the waiting lists. Yes. It's just about where we put it, and I think we just need to maybe acknowledge that and in the risk register as well, because I'm not sure we've fully done that since we took that pause out on some of our waiting lists. So let's take that into EMT. So we'll take that into EMT, but I've got a feeling we should rise it probably a little bit, to be honest, Stuart.
Yeah.
Thank you, Michelle, for that. Okay. I don't see any other hands up. So obviously we've had quite a big discussion about that area on the previous item that's led into this one, and I think we appreciate the EMT having another look at this when they get the next opportunity, and that will feed into the Q3 reports as well, won't it? Great. Okay, thank you very much, Oliver. Thanks for your waiting, and actually, well, I'm glad we actually had that conversation before that you were able to listen to as well. Thank you. Okay, therefore we will now move on to Finance Committee Assurance Report. Keith?
Thank you very much, Caroline. My first meeting as chair, which was very enjoyable. I think Pete's kind of touched on a couple of these. I think I'd take the report as read. I'd flag a couple of things around concern. One was around the increasing ICB financial position, which Pete alluded to in his conversation, and the potential risk that bears on us as being part of that ICB. And also specifically for us around our month 11 and 12 position. Pete talked in his paper about the fact that we are, expecting ICB monies, and that money's been confirmed. But in the event that money didn't arrive, then that would put us in a much more difficult position in month 11 and 12, and around our potential year end. Those are funds in lieu of around £1 million. So just raising those for awareness more than anything. And then a couple of actions on the right-hand side that, interestingly, flagged to the conversation we've just had around BAF. But in the review of the BAF scores that are relevant for finance, we had a debate, and I think pushed back to Michelle took back for the EMT to review around the BAF risk scores around finance because of that elevated system risk and our elevated risk in month 11 and 12. There was just a kind of conversation about does that BAF, and particularly does some of the content of the BAF reflect that increasing risk, and do we need to review that and come back with a slightly different view of that risk? And Michelle and the EMT were going to review that. And the other area for note really was around medium-term financial planning, which obviously starts and we'll re-look at the finance meeting in February. But Pete agreed that we would go away and try and look at both the trust and system level and the implications for that in lieu of the tighter financial position and what bearing that brings on those medium financial term plans. Other than that, I think I take the report as read.
Thank you, Keith. Any comments from board to Keith? Okay, thank you very much. We'll move on to Dean, People and Organisational Development Committee.
Thank you. And report there, just a couple of highlights, really, just some positive news around vacancy rates sort of falling and turnover being low, on all those things being lower than they have been for some significant period of time. We also had an update from the Director of Medical Education, really sort of successful interventions that have been made there over a number of years to sort of improve the experience that our resident doctors get, and also had updates on the growth that we've got in resident doctors and doctors in training as well. Karen touched earlier that continue to focus on sickness absence and doing that sort of additional work with Lynn around some of the operational areas. And also, although our statutory mandatory training does remain very high, as part of that continuous improvement, we're always looking at areas where it isn't so. And one of those was in medical staff. So just having a look at some of the reasons for, did not attend training or unable to access training, to see what improvements we can make there. But other than that, and the deep dives that we did, happy to take any questions.
Thank you, Dean. Any questions? No, thank you for highlighting those issues. We'll move on to Quality Committee. I think there's two here, isn't there, Phil?
That's right, the 19th of September and the 14th of November. The September meeting is an additional one that we put in to get through a lot of the annual reports. So we got some great assurance from some of those reports, really interesting, and also to see them develop year on year. I wanted to mention particularly the Action Plan for Community Mental Health User Survey 2023, and just to assure the board that we'll be monitoring the outcome against this plan. There's 6 items on the sort of recommendations, and we'll be looking how they develop. But I'm happy to take any questions.
Thank you. Any questions to Phil? No, thank you very much. Thank you for those reports. Mental Health Legislation Committee, Steph.
Thank you. Yeah, also my first meeting of this committee earlier this month. Some really positive areas of assurance around reducing restrictive interventions, which is continuing to be an area of focus. We've got, I'm happy to report there were no delays in discharge in terms of forensic services, and generally the mental health legislation use of them was pretty low. Just in terms of work in progress, there is, we'll continue to have a look at the new Mental Health Act work over the next few months. We'll be looking at Section 136 at the next meeting. We noted a lot of work going on further reducing restrictive interventions, and we had a detailed look at the role of AMPs, the approved mental health professionals in the system, which was excellent. We've asked for some further work to be brought to the committee on understanding MAPA and how it works to protect patients, and on public safety in a future meeting, which I think is really important. Has linkages, of course, to safeguarding across the trust, and also to the work that we've been discussing earlier on the Nottingham report as well, potentially. So we'll be looking at that for future meetings.
Brilliant, great. We had a successful interview process the other week for a forensics prison consultant psychiatrist, which was really, really enjoyable interview, wasn't it? I think looking at Kwame and Michelle who were on that, and hopefully that person will be starting soon.
Excellent.
Any questions to Steph? No? Okay, we'll move on to Audit Committee, Stuart.
Yeah, thanks very much. So once again, we met in October. We had a very positive discussion with support of all our kind of supporting parties for internal, external audit and counter fraud. A couple of things I just want to bring out. We had a really good discussion with the forensic division about their risk management. There was, I think, a very good tie-up between the way they used the risk approach and kind of actions they're taking in their operational day-to-day management. It was very very nice connections being made there. The internal audit plan is on track, and we continue to get generally good results. Although we had a couple of audits which I know Karen is on with because she was at the meeting explaining what she was doing. This is about not enough evidence of compliance, essentially by managers, compliance with the kind of the way we manage probation and sickness absence. That could be gaps in record keeping. It could be people don't understand what they need to record, but the auditors couldn't find the evidence that would allow them to give anything more than a kind of a low assurance level. But Karen, you're on that, aren't you? Which is good. And then on the external audit for the accounts for last year, that work is almost complete now. And I kind of had hoped that we'd bring the final audit opinion to today's meeting, but that's going to happen soon. and probably we'll have to deal with that in our December discussions.
Okay, thanks for that heads up. Thank you. Stuart, any questions? No? With you again, Stuart, on the collaborative committee?
Yeah, so we met in early October. I'll take the report as read. Two things I want to bring out. One is that all the providers have a routine monitoring status. This means our sort of quality and oversight of their activity means they're all in the sort of the green space, which is really good. Generally, across the 3 work streams, the kind of developmental work, the innovative explorations that are going on continue, which is always good to see. And the one thing that I think we should be concerned about, which I've raised before, is that we have got, although a reasonably small number in quantum terms of patients clinically ready for discharge, the cost of maintaining them in their current setting is over £10 million a year. If we could move them to another setting, we would use resources better. Back to my favourite theme. So it's another good example of where, at the margins, we could make a productivity gain. But to reiterate, I feel that this work continues to get some really good insights into how to make collaboration really work with a very active kind of commissioning function.
That's really helpful, and it feeds into the due diligence work we'll be all engaging over the months ahead as well, as the collaborative process and structure is going to be slightly changing and getting bigger. Okay, thank you. Any questions to Stuart? Thank you, Stuart. I haven't got any items to escalate. I've not been notified of any other urgent business. Review of the meeting, you'll see on the agenda. Have we focused on the right areas? Have the papers enabled people to perform your role? Debate, have you feel you've all had your say and we've had a good discussion? And have we all actually behaved in a way that allows everyone to play a part and do so with respect? Is any comments on any of that from anybody? Everybody happy that we've met all those? Michelle?
Yeah, just think it might be useful to
Michelle, you've gone mute again. Sorry, could you just repeat that? Sorry.
Okay. Can you hear me now?
Yeah, we can. It just literally just went off.
Okay, and it just might be, I know we mentioned it earlier on, but just for this section, it might be useful just to say that obviously we're going to take away the waiting list in relationship to the risk register and the BAF.
Yeah, absolutely. Thank you. Good. Okay, therefore I can close this part 1 meeting. Can I suggest we come back at 1 o'clock? And have a good half an hour, a bit more, 1 o'clock to restart for part 2. Thank you, everybody. And I hope those who are watching this now from outside, or maybe watching it in a week or two's time, feel assured and that we are talking about the issues that affect you and your families. Thank you very much.
Thank you all.